minutes, but I will try to see how I can go through it. Basically, before I start, I want to make this disclosure. I've done some studies on some of the instruments that I'll be speaking about here, or the techniques here. But I want to state that if I mention by name any particular item, it shouldn't be taken as a form of marketing strategy. It's just to, or some form of endorsement, is just to bring to the fore people's appreciation of the concepts that we are trying to propose, especially since there are some of the things that some people would have been working with. It's just to provide context. So starting off with, at what time do we do sickle cell diagnosis? What time is it available to be done? Well, it can be done at various times. It can be done before the baby is born. Let me just say that I need to be conscious of the fact that it's a multidisciplinary workshop. So I will try not to be as technical as possible, too technical, so that we all will follow. So it can be done before the baby is born, prenatally. It can be done immediately the baby is born, meaning that even at the labor room, as the baby is out, it can be done. And then anything post that newborn period, the first few weeks of life, it can also be done down to adulthood. There is no special preparation that is required prior to diagnosing sickle cell disease in an individual, but it's important to note that if there's been a recent blood transfusion, it's advised that you wait some time before you go ahead to do the test. Why? Because you may invariably be sampling someone else's blood, except if you're dealing with situations where basically you are doing some forms of genetic tests. But commonly in clinical practice, most of what we do will revolve around blood samples. So it's not advised that if there's been a recent blood transfusion, you should go ahead to do that. You want to allow the lifespan of the red blood cells and all that to dissipate before you go ahead to do the test. Now, what are the possible samples that we can use? I've already spoken about blood in the course of the earlier introduction, but we also have other samples that we could use. We could use chorionic villi. We could also use amniotic fluid. And it's important to note that when we say blood, there are different types. We could use cord blood, from the umbilical cord. We could use capillary blood, venous blood. And then I think it's also important at this stage to say that there are also instances where you can use the maternal blood sample, especially for some genetic studies, where you're able to pull fetal cells out of maternal blood. So when we're speaking about the blood, we're not just limiting it to the blood of the baby, whether it's cord or capillary or venous. We're also saying that with some innovations currently, fetal cells can be taken out from maternal blood, and it can also be used, meaning you can also use maternal blood if you're able to do genetic studies. Now, there are different types of tests, and I must say that with each passing day, we are having more and more innovative or novel techniques being brought forward. Many of them have not come into routine clinical practice because they need to undergo validations and be sure of the accuracy and all that. Some also because of cost and all that. So, but there are quite a number of tests. From early times, the sickling tests were the ones that were being used. And that was because it was shown that under certain circumstances, we know that the hemoglobin S will begin to sickle, especially when there is some form of deoxygenation. It causes the polymerization of the hemoglobin content of those red cells. And then they begin to sickle. And so by just looking either under the microscope or a cover slip, or even in a what you see in form of precipitation in a test tube, you can infer that there is sickle hemoglobin within those samples. And we have some other ones that have also come up, electrophoresis, where we're basically trying to use the differential charges that you will have, because we're dealing with hemoglobin, which is a protein substance. And we know proteins are made up of amino acids, amino group, and carboxylic acid group. And just because of changes in the structure of a particular hemoglobin, like having hemoglobin S as against, for instance, the standard hemoglobin A, we'll see that they behave differently in terms of how they will migrate under an electric field because of the changes of the amino acid components. And then we have other things like adaptations of the electrophoretic pattern, which is called isoelectric focusing, where gradients are now being used to ensure better band separations. And then chromatography, high performance liquid chromatography. We have the gene-based tests. And then what I captioned as the innovative novel techniques, some of which I said a lot of them are coming out as the days go by. Now, basically, the sickling or solubility test has to do with what I mentioned, where you use a particular, you try to put the hemoglobin components of the red cells into some form of situations that if there is presence of hemoglobin S, there will be some form of polymerization. And then that polymerization will be seen in a sort of, in quote, insolubility. Now, some can be done, like I said, using just a cover slip, and which requires microscopy to look and see whether they are now sickle-shaped red blood cells after you've done that, or the tube test, where it's sort of a sort of precipitation, and you can visually interpret it. So basically, you utilize a buffer, you use things like sodium beta bisulfate, okay, which stimulates that polymerization process and all that. And these were things that were done in early times. But the truth is that it was prone to errors. Prone to errors because one is that even the chemicals you need to be sure about them in terms of their stability, your buffers and all that, so that they can provide the desired effect of causing the red cells, those cells to sickle. And because it just targets the hemoglobin S, it also means that if someone is a trait, somebody has the trait or is a carrier, and by that, for instance, has hemoglobin AS, such a person can be given a false positive result. Why? Because he has some sickle hemoglobin S, he's going to have some sickle cells, whereas he's just a carrier. So he's not able to differentiate between traits and sickle cell diseases or sickle cell disorders. And then he's also prone to inter-observer errors. You see that someone may say, oh, I think this tube, the color shows that there's precipitation. Another person will look and say, no, I don't think it's precipitation. It's not dark enough for precipitation and all that and all that. So those are some of the challenges. But the good thing about it was that it can result, you can get your results within a very short time. And it's easy to do, but you require some training to do proper interpretations, especially when you're dealing with cases of traits or when you're dealing with cases that are not clear-cut. And the next set, which I put it here, is actually a later technology or technique compared to something like the electrophoretic techniques. But I put it here because it's also something that is easily done. You don't require much expertise, and it's coming into play now in terms of being a screening technique. So that principle is the lateral flow immunoassay principle. And what's the basis of this? The basis of this is generating antibodies to hemoglobin types. So generate an antibody to hemoglobin A or hemoglobin S or hemoglobin C, such that if you put a sample of a patient inside into that platform, if there is such hemoglobin type or variant, there will be immobilization by that respective antibody to that particular one. And then you can visually just read it out to see whether, oh, there's been a band generated, a line showing that there's been some antigen antibody complex formed, or the absence of such a line means that that is not there. But having said that, I need to point out something that it could also be in a reverse form. Instead of seeing a band, it could also be that the antibodies are such that it will knock off the ones that are there when there is a complex. It does not produce a color band. It knocks off that one. So the absence of seeing that color band means that that one is present, whereas the one that you're seeing are the ones that are not present in the patient sample. So it's either way, it can be a reverse form of it. And we'll soon see examples of what I mean by that. What has this helped us to do? These kinds of techniques for sickle cell disease diagnosis has markedly improved turnaround time. They have very good specificity. Quite a number of studies, especially in Nigeria and some other African countries, because of the resource poor settings, have been conducted on some of these items that utilize lateral flow immunoassay, and they've shown good results in terms of sensitivity and specificity. Because it is something you can use at the point of care, is highly scalable, meaning that you don't have to wait for centralized laboratory analysis anymore. There are things that you can do at the field, at the primary health centers and all that. And because it doesn't require much expertise, many people with minimal training will be able to perform it. And that ensures some form of scalability in newborn screening and other processes. Is qualitative, which is a drawback. So you can't use it to quantify. And for instance, we know that there are situations where you need to have quantification in order to categorize the type of sickle cell disease, sickle cell disorder that you're dealing with. Examples are what I listed there. Please, as I mentioned, is not to market this particular brand, but these are things that I know that so that I can provide context, because a lot of people would have been used to it. So these are examples. On the left of your screen is the hemotype SC. On the right is the sickle scan. Of course, the sickle scan is a cassette form, whereas this one is like your regular strip, the dipstick, your analysis strip, and all that. So, like I pointed out, like for instance, the hemotype SC uses the reverse approach, in the sense that if you do not see a positive band, that means that that particular hemoglobin variant is present in the blood. Unlike the sickle scan, which the presence of a positive band signifies that that particular hemoglobin type is within the blood. Now, let me just say that one of the key things here that is a quality control measure for this is to ensure that before you take any reading, that the control bar or the control band, as you can see, CTRL here, or control for the hemotype SC written there, that is showing. If it doesn't show, then please don't go ahead to do any interpretation. Look for another item, another strip or device to use. That means that there's obviously some malfunctioning of that particular device. So that's the quality control aspect of this. And like I pointed out, a lot of studies have been done on this, and they've shown very good sensitivity and specificity, greater than 90% in most of the studies. So that is something that quite a number of people are applying now because of the ease of use, little expertise, cost, and all that. Now that takes us to the next set of diagnostic techniques, electrophoresis. The first one here is the alkaline type, cellulose acetate electrophoresis, which is what is done in quite a number of labs across country. I speak in the context of Nigeria. A lot of private labs, that's what they do. Why? Because it's cheap, is also something that quite a number of technicians, lab technicians, and scientists can easily do and all that. It doesn't require too much expertise if you are someone who's been trained in laboratory processes. So, and because it's quite cost effective. But you see, it's I must say that it's more like it gives a false impression that because quite a number of people do it, that it's quite easy to interpret. What's the basis of electrophoresis? As I pointed out, because I need to move faster because of time, is movement of these hemoglobin types based on an electrical charge, an electrical field. Now, cellulose acetate utilizes buffers that are under alkaline pH, about 8.6, 8.4 or pH, whereas the citrate agar utilizes acidic pH. Now, cellulose acetate, unfortunately, cannot differentiate between certain variants. So you have that at the bands that you're looking at, some variants will migrate within the same band. So you have something like C migrating with E and O in the place where hemoglobin A2 is supposed to be. Okay, hemoglobin S migrating in the same place with, or hemoglobin D migrating in the same band as S. So he has that disadvantage of not being able to differentiate between certain variants. He's also prone to observer errors, because one of the key things that is one of the key determinants of what you get are pre-analytical processes. How you remove the hemosylate, how you apply your buffers, and everything. So those are key pre-analytical processes that have to be done properly for you to be able to have distinct bands and be able to interpret effectively. And like I pointed out, it's prone to observer errors too. And citrate agar, the acidic pH one, was brought up to try to obviate some of the challenge of not being able to, of alkaline cellulose acetate electrophore, not being able to differentiate between different variants. So it is not something that is commonly done, but it's something that is done when, for instance, you want to be sure that what you're seeing with cellulose acetate is the thing that is not that is hemoglobin D when you're thinking it's hemoglobin S. Is quite laborious, and it's very difficult to perform, especially in very poor resource settings. Now, the next form of electrophoresis is capillary. In this case, what we're using is you're using silica gels, right? And in the form of, in this case, you're using capillary tubes, right? Small glass tubes that are filled with electrolyte solutions that will help to separate the hemoglobin variants, okay, based also on the electrophoretic mobility. Remember, it's just a form of electrophoresis. One major challenge of capillary electrophoresis is that the capillaries because they are very tiny lumen and all that, they get easily blocked, and you have to keep changing them. And that can be a challenge in resource poor settings where those things are not manufactured and all that. So, but the good thing is that it's automated. It can also give you quantitative results, unlike what we saw with cellulose acetate or citrate agar and all that. Okay, so you can quantitate, and that means that you can apply it to things like when you're also looking at thalassemia, right? Because we normally use hemoglobin A12 to categorize what we are seeing. Okay, the quantity of or the percentage of hemoglobin A12. Okay, and so that's capillary electrophoresis. Just to say, as I move on to this next one, I must say that capillary is not something that is very widely used in Nigeria. Quite a number of centers use it, but not so much. More people tend to use HPLC in Nigeria than capillary electrophoresis. But let me just say that it's been shown that capillary electrophoresis can it tends to perform better than HPLC for quantifying hemoglobin A2. Okay, except when there's the presence of hemoglobin C. So if there's presence of hemoglobin, that advantage is not there. But basically, it tends to quantify A2 better. That means it will be a better index in identifying things like S-beta tau than HPLC. HPLC is based on the distribution of differential distribution between a mobile phase and a stationary phase. You use packing materials within it, various types of packing materials. It can be silica, it could be so many other things. And then these hemoglobin variants will elute from at different times, because some will stay longer with the stationary phase and migrate in a slower version than others that are not easily absorbed onto the phase, and then will migrate faster and elute faster. So based on the elution times, you can categorize the different variants. Let's just say at this point that just like capillary electrophoresis, it's expensive, both the cost of reagents, both the cost of the machine, okay? And it requires trained personnel to properly interpret the results. But the good thing is that just like capillary electrophoresis, you can use it to test the newborns. It's quite good in differentiating hemoglobin F and all that. And then you can also use dry blood spot. If you remember where I was talking about the various samples, we know that if you're dealing with a newborn, you're not likely going to be collecting whole blood because of the volume that you will need maybe in the EDTA tube and all that. So basically DBS is what is used. So you want systems that can utilize DBS to be applied to newborn screening. And that is one advantage of HPLC. The next one is a modified form of also a modified form of electrophoresis. In this case, what is being done is to create a gradient. So instead of just using a buffer that does not have gradients, you use a buffer that has differential pH gradients. That way, it helps with greater differentiation of the bands, unlike your typical electrophoresis, let's say cellulose acetate electrophoresis. So because of the pH gradient, you find out that the bands will separate better. Why? Because at some point, a particular hemoglobin type will stop migrating. If it gets to, we call it the isoelectric point. That means that at that point, for that particular pH, it bears no positive or negative charge anymore. So when the net charge is 0, it will stop at that place. And that will be different from where another type of hemoglobin will stop. Because remember, I said changes in or differences in amino acid content will determine how they will migrate on that electrical field and all that. So that's the basis of IEF. It gives better resolution. Why? Because you're dealing with a gel that has a pH gradient. And one, it's scalable, because you see you can stack up IEF chambers. You can do like 4, and each one can run 100 and something. So basically, it's highly scalable in terms of how many samples you can run. Relatively, compared to HPLC and other, it's relatively less expensive, but compared to things like cellulose acetate, it's still expensive. I put a question mark on qualitative. Why? Because I know the traditional IEF is qualitative, but currently I know a company that maybe towards early next year is going to have a quantitative version of it. They're working on that. And what they're just going to do is to find a way of using computer systems to scan the bands and quantify it. I'll also let us see. So this is an example of an illustration of IEF gels. Please, I need to move on fast now because of time. But you see that there's the potential risk of poor results, either false positive or whatever, because if you're dealing with degradation products, it can show as bands, and that can give a poor interpretation of the results. So what it means in essence is that how you collect the blood sample is key, and how you store and transport the DBS is key. If you don't store it properly, there can be degradation of hemoglobin, and that can affect the bands that you're going to see and make interpretation poor. These are just some examples to show us good collection and bad collection, and not just about the collection, but remember about the transport and shipment. You need to, for instance, ensure that you have it with desiccants and all that to reduce moisture. And then it's always advised that you should also try not to delay the time before analysis to reduce the likelihood of degradation of the hemoglobin. But it's something that at least currently in Nigeria, two major centers are running newborn screening programs supported from abroad, and that is that's the technique that is being used. Okay, it requires a lot of expertise in terms of being able to run it, because so many things can affect it, how you blot the gel and all that. So it requires a lot of expertise, and that's part of the disadvantages of IEF. PCR, we're going to the genetic-based ones, and I'll just quickly just go through these ones because I see my time is gone. Basically, genetic-based tests are one of those ones that are commonly applied in prenatal diagnosis, right? So, and is the go-to, in summary, is the go-to when there are discordant results with some of these ones that I've already mentioned. And there are various forms, traditional PCR being used to amplify the mutation zones, and then going ahead to do gel electrophoresis and some of these, or high resolution melting analysis, or even gene sequencing to identify those genetic mutations. RFLP, resolution fragment length polymorphism, was one of the procedures that was one of the early genetic procedures, let me put it, that was applied to sickle cell disease. And what is this? You're just using a resolution enzyme that will cut at specific places, and based on the length of the fragments, you would compare with a standard to say, oh, there's hemoglobin S here, there's no A, there's hemoglobin A here, and there's S, and that's AS and all that. This is just an example. So what it means is that when there's a mutation, some of the restriction enzymes, once there's a mutation, they are not able to cut at particular points. Absence of a mutation, for instance, they will cut at a particular point. And that means you're going to end up with different fragments depending on whether that person has a mutation or not. And that's the principle of RFLP. Other forms of genetic testing include DNA microarrays, and then the sequencing techniques, whether it's next generation sequencing. And then I want to move on to something that quite a number of us are getting now. I have said that there's been a lot of innovations over time, and with greater percentage of new products or items coming in. This is not to advertise this, I will keep mentioning, but just to say that this is just a miniaturized form of cellulose-assisted electrophoresis. We've always known it to be a qualitative form of test, but now it's been done in such a way with some software such that it can actually quantify the bands that you get after the electrophoresis, and that's the basis of this. And this, quite a number of centers within Nigeria have begun to apply this, especially in terms of using it to quantify fragments like hemoglobin F and all that, or even when exchange blood transfusion has been done to check the various percentages of the hemoglobin, whether it's hemoglobin A and S and all that. So it is something that is currently in place, and over time there's been improvement in the software. Initially there were issues, but software updates have been able to make this quite a reliable chip-based method that reads out cellulose acetate electrophoresis. And it's important to also note that apart from hemoglobin electrophoresis, the machine is being adapted now, the cartridge, to read some other cartridges that can do some other analytes, maybe things like ferritin and all that. So lastly, I want to talk about image processing techniques. Quite a number of image processing techniques have been tried to be introduced, where you use microscopes connected oftentimes to smartphones, built-in AI and all that, to like identify presence of hemoglobin S or any of the sickling type of hemoglobin variants. I must say that, unfortunately, most of these tend to use images that have to do with the diameter of the red cell, the degree of pallor and all that. And we know that those things can vary a lot. And such, these imaging processes, many of them have not been validated because they have difficulties distinguishing between different types of hemoglobin variants, especially when there are close similarities in terms of red blood cell diameters and the rest of them. And in fact, in the presence of hemoglobin F, most of them find it difficult to do proper interpretation, especially since what you're dealing with is like a binary classification, okay, which we ignore certain things, and they're just using differences in shapes or differences in sizes and all that. And we know that certain other things can affect the size of red blood cells outside of hemoglobin variants. Then we have the phase techniques, which are basically based on densitometry. Okay, many of them just use ultracentrifugation methods and other things to separate. Unfortunately, this will require a trained, quite good expertise to be able to interpret. And then, expectedly, you will not be able to easily differentiate between the disorder and, for instance, sickle cell trait. Why? Because in traits, there will be combination of things like hemoglobin S and A, and that can affect the outcomes. So I think all these other sets, I just want to say that we also have innovations trying to use cytometry, flow cytometry, in which case that looking at how the cells flow and all that to also, but these are all innovative techniques that have not really been brought into clinical practice because they have not been proven to be reliable and shown consistent results. I guess maybe with time, with better adaptations and all that, they may come into practice. Nanopore is one of those DNA sequencing ones. I know also a couple of centers have access to this, where the molecules pass through a nanopore and you get to produce what is called a squiggle. And what is that? Changes in the DNA. Okay, we know that what drives sickle cell disease is the genetic mutation. For instance, we are dealing with SS, we are saying that thymine has replaced adenine at codon position 6. Just that nucleotide change would affect the way that these molecules will pass through the nanopore, through the membranes and the current that is passed. And then that process generates like a signal that is read out. I just showed this so that we see how small the nanopore is, and you just plug it to the laptop, and then with the software, you're able to interpret whatever you read. As I end, let me just say, what should we be doing? Yes, there are a lot of innovations and all that, but I think that we should be looking at practical things that can help us to scale up diagnosis of sickle cell disease with greater efficiency and better accuracy. I think my own thinking is that we should go with those things that can easily help us to screen. But as we're doing that, we'll let the people know that, no, this result you have is a screening result. We still need to go ahead to confirm it, right? So that the cost that is associated with things like HPLC, capillary electrophoresis that is used for confirmation will not necessarily be what we'll be subjecting everybody to. If someone has screened and that person, for instance, has screened with a point-of-care testing device and is showing AA, then you're not likely to say, oh, please go and do a confirmation. So that way we can scale up the screening processes across the country because of less cost, because of less expertise required and all that. I also want to end by just telling us about an innovation that is related to some of the things I've talked about. This is a publication where you are dealing with point-of-care testing devices. One of the disadvantages is that the baby has to be there with you. You go there where the baby is, you're collecting the heel prick into the tube, if it's with a buffer or whatever for sickle scan or stool, and then you're checking. That means that if the babies don't come to centers like primary health centers or your hospital, you don't have access to them. Okay, but we know that sometimes some of these babies, even if they're born outside the hospital, will still come for immunization. The mothers will bring them for immunization. So it means that it's possible, and then you have to do the test right there and then, right? That means that someone who is trained has to be on hand to do it every time. But you see, studies have started showing, trying to look at this point-of-care testing devices. If we collect the blood in dry DBS, can we still go ahead to use it and apply it and all that? And there's been good findings to show that, yes, this can be done. Meaning that you don't necessarily have to do it at that point of care anymore. You can collect the blood samples. I know studies are still ongoing. Collect the blood, the nurse, the community health extension worker at the distant rural PACs can collect these samples on DBS, store it, and then it's pulled centrally where you have good expertise for them to now do and good interpretation, to do interpretative expertise to do the screening, the diagnosis of the screening process. And then based on what they find, they can go ahead to now call in the patient for confirmation and then bring the person into care. I think at this point I will stop. Sorry, I've overshot my time. I want to thank everyone, and I'll be available to quickly take any questions. Thank you.
Thank you very much, Professor Maxwell. I'm very sure that 30 minutes is too short a time to go through all you have gone through. So we appreciate that you're able to manage that time that way. We'll quickly take a few questions because Professor Maxwell will be stepping out shortly. We can't take his question at the end of the presentation. So please, if you have questions, very quickly, we'll just take one or two. Then if you have other questions, you can type in the chat box. So the first two people that have raised their hands, I will call them to ask questions. If not, we'll move to the second presentation. So thank you so much, Professor Maxwell, for an excellent presentation. While we wait for one or two questions, the next presentation will be taken by Dr. Fakuri. Dr. Fakurin is an associate professor in the Department of Pediatrics, University of Jos. He's also a senior lecturer at University of Jos. And then he'll be taking the topic acute sequestration crisis in sickle cell disease. So, do we have questions for Professor Maxwell? Okay, so yes.
I see nobody noticed my hand. I just want to say that Professor Maxwell has given a very, very exciting presentation on diagnosis of sickle cell disease. It's actually one for the museum. It's really wonderful, and I want the medical students and the junior residents, in fact, everybody to have a look, listen again to that erudite presentation. Professor Maxwell, thank you so much for covering that ground very well. Thank you. Well done.
Thank you so much, Prof, for those comments. Yes, the presentation was quite excellent. So we'll be moving into the second presentations. We don't have questions for Professor Maxwell at the moment, but please, if you still have questions, type in the chat box or keep them at the end of the presentations. Those will be responded to. Dr. Fakuri, are you ready?
Oh, Mr. Ruben, thank you. Yes, I'm ready.
Okay, so but before you start, we noticed that people are joining the call and yet to respond to the pretest. The link is on the chat box. Please feel free to respond to the pretest. Even if we've had Professor Maxwell's presentation, it doesn't matter. Please go ahead and respond to the chat. Dr. Fakuri, please, you can go ahead. Thank you.
All right, thank you very much. I want to start by appreciating the principal investigator, Professor Inodu, for this opportunity to make the presentation. So this morning, I'll be talking about acute sequestration in sickle cell disease. So this will be our learning objectives, for us to be able to, at the end of this lecture, that we'll be able to understand the pathophysiological basis of acute sequestration crisis, and also to be able to identify how patients present with acute sequestration crisis and the management strategy that has been proven to be evidence-based, and more importantly, for us to be able to, understand what we're going to communicate to patients so that we'll be able to prevent, future occurrences of acute, either to prevent initial or future occurrences of acute sequestration crisis. So now, what is acute sequestration crisis? So I want to say that, usually there's actually the term in the literature, acute splenic sequestration crisis, because we also have the hepatic crisis as well. So meaning that the sequestration crisis can occur in the spleen or in the liver. But most times we have more of the occurrence in the spleen than really in the liver. So while talking, we'll be talking more, discussing the spleen, but that doesn't mean that what we're saying can also not occur in the liver. So as a way of definition, it's actually defined as acute splenic enlargement that is associated with a drop in the hemoglobin level. Usually, it's been said greater than 2 grams per DL from the steady state level, or if you don't actually know the steady state level, that's maybe you recently have the hematocrit level for the patient. So 20% from the baseline level that you have, if there's a drop and there's splenic enlargement, so that actually qualifies for acute splenic sequestration. So there's a third aspect of the diagnostic criteria, which is the presence of reticulocytosis, increase in the reticulocyte count. So we're going to get to that later. So basically what happens is that the red blood cells are trapped in the spleen or in the liver, so causing the enlargement of the spleen and the liver. So, and you discover that the blood is being pulled away from the circulation. So I want us to view acute sequestration crisis as a condition that someone is bleeding, but the bleeding is not outside. So it's exactly the same like that. In which case is a life-threatening complication. For instance, if someone is involved in road traffic accident and you've bled a lot, so the person will go into hypovolemic shock. So, and it's the same thing that we have in acute sequestration crisis, only that the bleeding is internally, is not going out. So it's one of the earliest life-threatening complications that we see in sickle cell disease. And in addition to infection, it has been found to be the major cause of mortality in children less than 3 years of age. So we're going to start this by making a case report for us to be able to bring the points home. So there was actually a child that presented to the emergency room, a 1-year-old boy with diagnosed with hemoglobin SS. 3 months prior to that time, was diagnosed at 9 months of age. So a week before presentation, the boy had fever and symptoms suggestive of upper respiratory tract infection, catarrh, cold, and so on. So on the day of presentation, some few hours before presentation, so the mother noticed, as in what actually really caught the attention of the mother, was the child suddenly became weak and with sudden onset of breathing difficulty. So prior to that time, the child was not feeding well. So, and the child also suddenly appears pale. Then the mother decided to come to the hospital. So from the examination findings, it was found that the patient was severely pale. The pulse was very fast, 220 beats per minute, and the volume very low. Then the respiratory rate was 40 breaths per minute. Then the blood pressure 70/40, which is very low. And it was found also that the child had splenomegaly. The spleen was 6 centimeters below the left costal margin. So, with this, especially with the splenomegaly there, it actually brings out the diagnosis that we must be suspecting that we're dealing with acute splenic sequestration crisis. So from the investigation, hemoglobin level was 4 grams per DL. Then the white blood cell count was raised, platelet low, and reticulocyte count, which we're going to talk about later, was not done, but is a major investigation that we need to do. So a diagnosis of acute splenic sequestration crisis was made. So immediately the child was placed on intranasal oxygen, IV fluid with normal saline was administered, transfusion was given, and well, to God be the glory, the child survived and was discharged. So, well, this is actually a good story, but it doesn't usually end like this. In so many instances, even the patient will have died before getting to the hospital, or even by getting to the hospital, they will have died. So the important point that we're going to learn this morning is for us, as in what are those things that we can do to be able to detect these, so that we can teach the parents to detect that, they present early, and the outcome can be better. So now, in terms of the distribution of acute sequestration crisis, it's commoner in children generally, and especially less than 5 years of age, and more importantly, in those less than 3 years. But again, it can also occur in adults, especially adults with hemoglobin SC. They can still have acute sequestration crisis even later in life. It has been documented. So, and the prevalence in under 3 has been, is as high as up to 30% from the literature. So, it's something that is very important because of the life-threatening situation, the life-threatening nature of the problem, that we need to pay attention to it and address it appropriately. So again, among those taking hydroxyurea, even we also have the experience in the Jos University Teaching Hospital, because usually in hemoglobin SS patients, by the time that most of them are getting to the 6 years of age, some have developed auto infarction of the spleen, so that the risk of acute sequestration crisis is no longer there. But those taking hydroxyurea, because of the preservation of the splenic function, so the spleen can still be there beyond that age. So the import of this is that, yes, why we're taking hydroxyurea, which is actually a very good one, is not a negative. It's actually a positive that is preserving the splenic function, because it will also help the patients to fight infection well. And as I've mentioned earlier, that infection is the leading cause of death in them on the under 3 age. So, but for us to now be able to also be very vigilant, so that you won't say that, oh, 8-year-old with hemoglobin SS coming with some features suggestive of acute sequestration crisis, that we may be thinking that, oh, no, this age, we shouldn't be having such at this age. So it can happen in those with on hydroxyurea. So what is the pathophysiology of this condition? I want to state that the exact sequence of the event is not well known. But what is known is that usually there's a sort of a precipitating event, majorly infection, which may trigger sickling of the red blood cells. So in such a way that there's obstruction to the flow of blood in the splenic circulation. So with this obstruction, then as more blood gets into the spleen, then they get trapped. So in some instances, the obstruction can be relieved and everything resolves again. So, but in most times, if the obstruction is extensive, then you discover that a lot of blood can be pulled there massively, to the extent that a patient can actually develop shock, and usually the presentation is very acute. within few hours, this can happen and the child can be dead. So the clinical features that we need to pay attention to. Because of the trapping of the blood, usually the patients they present with abdominal pain. You know, it could actually be like a sort of vague abdominal pain, then and also swelling, which basically is the spleen that is swollen there, the spleen or the liver, as the case may be. Then they can have fever from the whatever infection that could have been there, that could have been a trigger. Then the patients are extremely tired because of severe anemia. They're lethargic, headache, dizziness. They can have pallor. All these are related to the fact that there's no blood in the circulation. So from the examination finding, checking the liver, we have splenomegaly. Then features of shock, tachycardia, tachypnea, hypotension will also be present. So all these are pointers to the fact that we are dealing with acute sequestration crisis, and this is an emergency. So basically, in terms of making the diagnosis, the enlargement of the organs are very, very important. So, and as a matter of fact, the diagnosis should be made clinically as much as possible, clinically with some blood investigation. So we don't have to wait that, until I want to go and do ultrasound, before I can confirm the diagnosis. No, we don't have time to waste. So that with all those initial features, then you do your prick and you obtain your blood. You discover that the PCV, within 5 minutes, the PCV is actually very low. Then you palpate the spleen is enlarged. Please, straight to the treatment without necessarily waiting, to do any imaging test. So that samples also should be obtained for full blood count, which will show reticulocytosis. So the reticulocytosis is important. I'm going to show this in the next slide for us to be able to differentiate the acute sequestration crisis from a close differential, which I'm going to mention next. So, then other supportive investigations can also be done for us to, just to support this. But this basically can help us to make a definitive diagnosis. So now, talking about those other differential, the most important one is red cell aplasia caused by parvovirus B19 infection. Because it's not in all instances that the spleen is actually massively distended. So a patient who can also come, a sickle cell patient with worsening anemia, having some of those other features that we mentioned. Yes, with the splenic enlargement, we can say that, this is sequestration crisis. So, but the reticulocyte count will be the one that will help us differentiate between red cell aplasia, that's parvovirus B19 infection, causing acute drop in the hemoglobin level. So in this, you discover that the reticulocyte count will be low. But in sequestration crisis, the reticulocyte count will be high. So from this table, you can see that, low hemoglobin, high reticulocyte count, then the organ is enlarged. In case of spleen, that is splenic sequestration. If it is the liver that's enlarged and we have low hemoglobin, high reticulocyte count, we'll be talking about hepatic sequestration. So, and again, we have low hemoglobin, high reticulocyte count, then the spleen is unchanged from the steady state, everything is fine. So it can actually be an increased hemolysis from acute episode, from acute crisis of sickle cell disease generally. So how do we manage? As I mentioned earlier on, that is a life-threatening condition that we need to approach with a very serious sense of urgency. So initially, especially for those that are have hypovolemia, that in hypovolemic shock, we have to first give anti-shock to make sure that we correct that, so that we give intravenous normal saline to be able to achieve volume resuscitation. Then the blood transfusion, very important, so that it will be able to correct the severe anemia and also restore the blood volume. So you discover that as you give the transfusion, then the spleen will be able to increase oxygen delivery to the tissues generally, and also even to the spleen, so that the function can actually recover and some of the blood trapped there are also released. So it's important for us to note that we also have to be cautious about the transfusion. You don't just push everything in and the spleen releases the content, what it has inside of it, and eventually we now have another problem of over transfusion and increased viscosity that can complicate the matter and even make the child to have a die of heart failure. So we must transfuse cautiously. We transfuse and make sure that we monitor the hemoglobin level, as in to do the hematocrit, so that we transfuse and monitor. So that is very, very important. So now talking about the choice of blood, it's actually preferred that we use packed red cells. It helps to increase oxygen delivery to the tissues generally. It will also help restore the blood volume. Whole blood can also be used if there's no packed cell. So, but preferably to use packed cell. So that if we have whole blood, you can actually allow it to sediment a little, so that it will be like a sort of sedimented cell. Because giving whole blood alone, it can increase the risk of volume overload that we mentioned. But that doesn't mean that if we're in a center that you don't have access to packed red cells, yes, you can get whole blood, just allow it to settle a little, and that can be used and everything will be fine. So, and also in cases that, in cases of severe crisis, the severity is actually measured by, the drop in the hemoglobin level and also the splenic size. So even in such instances, we may actually do exchange blood transfusion to be able to save the life of the particular patient. So monitoring, very important, so that we check the vital signs, the hemoglobin level, and keep monitoring the splenic size, so that it's extended, then it will keep on reducing gradually until eventually later everything will normalize. So delayed treatment is very dangerous, as it's actually a very common cause of death. So it has been reported that among patients with the first episode of acute sequestration crisis, in even best of centers, like 12% of them will die. And for those that have had it before, if they're having a recurrence rate, 20% of them will die. That's in the best of the centers. And you discover that in some centers that, we don't have enough support, even the mortality can be absolute. So then antibiotics is also very important. We said that it can be triggered by infection, so that generally to just give antibiotics to cover whatever infection that is prevalent among sickle cell disease in your own environment. So what are the preventive strategies, which I said is very important? So this is part of what has been incorporated into newborn screening, and one of the benefits of newborn screening. We know that when we do newborn screening, we make the diagnosis early, such that penicillin can be provided, hydroxyurea can be provided later. Then another important component is patient education. So, and part of the patient education that is important as part of the package for comprehensive care under newborn screening is to teach parents how to be able to palpate the spleen. Acute sequestration crisis has been reported in a child as young as 3 months. So meaning that immediately diagnosis is made from our newborn screening, we teach them how to palpate the spleen so that, teach the patient how to palpate the spleen. Most times they will not feel it at that time. So that telling them that, okay, this is how you palpate it. Once you feel the spleen, please escalate and just come to the hospital so that we'll be sure of what is going on. And also to be able to recognize some other signs, like, the child being pale, being weak, before even getting to the pallor aspect, the child being weak, the lethargy that we're talking about, the pallor, so that, and the need to seek urgent care, not that the one that, I want to just observe the child for another 6 hours, another 12 hours, or let me just see what happened overnight. Tomorrow we'll get to the hospital. That tomorrow may not come. So we need to teach them very well. Then also in our own clinics, as physicians, when they come for their routine care, especially those younger age group, up to 5 years of age, and especially under 3, let's make sure that we always check their spleen as well. So then another preventive strategy is about giving short-time chronic blood transfusion. So this has actually been used, especially in younger age group that has had, those that have had previous sequestration crisis, in order to buy time to till the time that splenectomy will be done. So, but recently it has actually been advocated that splenectomy can be done at a young age, provided that the patients are vaccinated, you give prophylactic penicillin, they will be fine. Because the risk associated with leaving a child that has had a prior splenectomy to stay like that, as in the name of buying time, that until we get to 5 years and beyond before we do splenectomy, the child can actually die before then. So that splenectomy should be done as soon as possible. Then another limitation of the short-term chronic blood transfusion is about the risk of alloimmunization, which can occur. It's a common risk among those on long-term transfusion. So we don't want that, and apart from, the risk of transmitting infection. So, and in studies, it's also been shown that those on short-term chronic transfusion, if you stop after like 3 months, they can have episode of acute sequestration crisis. So short-term chronic blood transfusion is good, but if our patients have confirmed acute sequestration crisis and we're able to manage successfully, let's just discuss with them the need for splenectomy to be done. So finally, what are the take-home points that I want us, to actually have from this lecture? One, for us to know that acute sequestration crisis is a life-threatening complication of sickle cell disease occurring in young age groups, but can also occur even in older persons that require urgent attention. And the second aspect is about the need for early recognition and timely intervention. So for us also doing our triage, so that if patient comes, to triage them very fast and act appropriately, because delay in triage will actually could translate to mortality. Then, very, very importantly, the caregiver education on recognizing signs of acute sequestration crisis, in which case that we need to teach them practically and observe them demonstrate such, so that we know that, okay, they know how to do it, and ask them to remind them, do you do this routinely? With that, if there's going to be any problem, it can be detected early and treatment can be given and everything will be fine. So I want to appreciate everyone for listening. So I'm happy to have questions so that those areas that we need to clarify them more, then I can shed more light on that. Thank you very much.
Thank you so much, Dr. Fakuri, for that exciting, excellent presentation. I enjoyed the fact that you were able to present cases, give me more understanding on what acute sequestration is. So please, we have some questions on the chat box. If you want me to read them out, I can go ahead so that we can take those ones and before we move to the next presenter. Yeah, so this is from Lutz. He said he or she says, case report on acute sequestration crisis. Please, with WBC of 33,500, I did not see the outcome if antibiotics was prescribed / use aside transfusion and use of crystalloids. Just want to know more. So please look at that question. And then one more question down says, is there any place for ICU care for a positive vicious circle acute sequestration case noticed to have worsened after transfusion of packed cells? Or sir, what do you advise? So please, these are the two questions in the chat box. You can respond to them while people who want to unmute and ask questions can get ready. So please go ahead, Prof.
All right, thank you very much. To the first question, you know that so as not to overpopulate the slide, what the slide talking about the treatment that was given. So I was actually discussing the treatment. I didn't put everything there. If you listen very well to my presentation, I mentioned that antibiotics must be used. So in that index patient too, antibiotics was given. So I also mentioned it later that antibiotics is part of the treatment that even should be routinely given in a patient with acute sequestration crisis. You know that the problem is that even at that point, the splenic function is also impaired, so that the susceptibility to all those invasive encapsulated organisms like Streptococcus pneumoniae, Haemophilus, influenza, they are actually very high. So that we need to cover for those with antibiotics. So for the index patient, antibiotics was used. Then, okay, talking about the need for ICU care, very well. As I said, that is a life-threatening condition. So that usually sequestration crisis is actually being treated in high dependency units, like the ICU and the HDU, depending on whatever you have in your system, in your setting. So an oxygen will be given. Then talking about crystalloid, I mentioned it that in the patient that normal saline was administered, so crystalloid will be given, especially that they are as in presenting with shock, so that you have to give anti-shock while waiting for your blood. So that is actually that.
All right. Thank you so much, Prof. Dr. Collins, before we go to the next question on the chat box, Dr. Collins, please unmute and ask your questions.
Thank you very much. Thank you very much for the presentation. Please, I'd like to know. I'd like to know for.
Sorry, I can't hear Dr. Collins.
Okay, thank you very much for the presentation. I would like to know, please, for non-transfusion accepting sex like Jehovah's Witness, is there a certain protocol if a child whose parents are Jehovah's Witness come around with maybe the child comes down with this disorder? Is there a protocol that could utilize where there won't be need for blood transfusion?
Yeah, okay, thank you. Thank you very much. You know, this is actually a very important question and with ethical component to it. So for a Jehovah's Witness patient presenting with acute sequestration crisis, and especially if it's actually a severe one, it's actually a very dicey situation because of the mortality. So, but generally in approaching a patient with Jehovah's Witness having a child with that requires blood generally. so that there is a protocol for that. You know that the child doesn't have autonomy, cannot make decision on their own. So that it's actually inherent on the pediatrician to, to protect the interest of the child, to act in the best interest of the child. So usually what we do is to counsel the parents and talk to them. So at times, we've seen instances that they will agree and they will tell you to go ahead and do the transfusion. So, but if that is not the case and they still refuse transfusion, so that you have to escalate that to, contact the management of the hospital, the ethics committee, and for a court injunction to be obtained. But I know that that's a longer process, but the ethics committee can actually take some decision while approaching the court so that the order to transfuse the patient can actually be given so that the patient can be transfused eventually. So that is the way that is being addressed. Then
Thank you so much. Okay. Yeah, go ahead, sir.
Okay, but have I been able to? I saw that you posted another question. That is there any scenario?
Thank you very much for your response, sir.
Okay, you're welcome. Is there any scenario where the patient may need to be taken to the theater for splenectomy? So in the setting of acute sequestration crisis, emergency splenectomy is not indicated. We'll talk about emergency splenectomy if there is splenic rupture. So, but usually in the context of acute sequestration crisis, there's no splenic rupture, because if, for a patient that will have splenic rupture, usually there's a contact injury. So, for instance, a patient that has actually been managed for acute sequestration crisis is now recovering and hemodynamically stable. Part of the instruction that we'll give them is to tell the child for the meantime not to involve in contact sports or in aggressive play that could also harm the spleen. But in the acute phase, even the patient, they are actually too weak to do anything. So we're not talking about rupture at all. So we don't talk about emergency splenectomy. What we do is to treat. And after the treatment, the current thing is to be able to actually start educating them about the need for the child to have splenectomy. Some authors have actually said that after one, we talk about splenectomy after having some recurrent episodes. Some have actually said that after one episode of acute sequestration crisis, especially if it's severe, then we should go ahead and counsel them, educate them about the need for splenectomy. So now that takes me to another question that is being asked. Which class of patients should we do EBT for in acute sequestration crisis? So those class of patients are those with severe crisis. So, and how do we determine that the severity of the sequestration crisis? It's actually being measured by the drop in the hemoglobin level. So that if you have a drop in the hemoglobin level of greater than 4 grams per GL, it's actually a severe case. So such a child, if we know the steady state before and there's significant drop, and usually in that instance too, it's not just only the hemoglobin drop, you discover that the spleen also is so massive. So such patients can benefit from exchange blood transfusion. And if exchange blood transfusion cannot be done, we can still go ahead and do transfusion and give supportive treatment. The outcome can still be good.
Okay, so we have one more question, then we can move to the next presenter for the sake of time. That is from Khadiza. He said, I learned that some patients need to remove their spleen. Is that the scenario? What happened to the function of the spleen in human body?
Okay, so
is that the scenario? What happened to the function of the spleen in human body?
In human body, yes. So thank you very much. So the function of the spleen to filter blood for the protective role of the spleen. So what is being done is that after splenectomy, the patients are placed on are vaccinated, giving pneumococcal vaccine, Haemophilus influenza vaccine, which is part of the vaccines that we have now in the Nigerian program of immunization. So they will be vaccinated and they will be placed on penicillin. So with that, we can actually be able to protect them against infection, then with some other supportive treatment as well. So that is actually better done than leaving the patient to have another episode of acute sequestration crisis. You know, usually this is done for recurrent, the main protocol is actually recurrent sequestration crisis. So that it's better to actually do that and we'll cover them, and that will be able to take care of the function that the spleen will have actually done in the function of the spleen in them, than to leave them to have a recurrent one that can actually kill them eventually. So basically, it's infection that I want to treat. And also for me to add that even most of the sickle cell patients, some at an older age, after like 6 years, they have autosplenectomy. And even those that have the spleen, they have hyposplenism, meaning that the spleen is actually not functioning optimally. And that's part of the reason also that we emphasize vaccination and also giving penicillin prophylaxis. So they will be fine. After splenectomy, ensure that vaccination has been done. If not done, do it. Then continue with penicillin prophylaxis. They will be very fine. Thank you.
Thank you so much, Prof.
So I think another question. Okay,
yes, we'll take more questions, but this time around, we would like you to send them all in the chat box for the sake of time. We will take them at the end of the presentations for today. That's okay with you, sir?
I'm very fine with that. Thank you very much.
Okay, thank you so much, sir. So our next presentation will be by Professor Nnodu. I don't know if you can, sir, please, if you can stop sharing your screen now so that, yeah.
Okay. Yeah, good morning, everyone. I'm delighted to make this presentation. I must say that it's been really exciting listening to Professor Maxwell and Dr. Fakuri. We are going to put these presentations on our website because I know that 73 is not quite the numbers that we were expecting. And we would like to have this in the iCard so that people can just listen and learn. Because we just don't want to only talk about this. We actually want to be able to implement better management of patients with sickle cell disease, not only in Nigeria, but across Africa. So these are very exciting times. I'm delighted to make this presentation, and I must say that this workshop is as a result of the Fogarty D43 training grants that we have from the National Institute of Health, and we are working out of 3 African institutions and NYU. So we have myself, Professor Dr. Emmanuel Pepra, Professor Priska Dejumo, Professor Fred Safo from Kwame Nkrumah University of Science and Technology, Professor Dejumo from UCH, and a number of co-investigators that are actually involved in this training program. And the aim is not just to have a training program only for tertiary healthcare workers, but across board, down to the primary healthcare centers. It's multidisciplinary. And so we want us to invite our colleagues, all the people that we are working, looking after sickle cell patients with in our hospitals. So this is really it. And then we'll put the materials on the website so that everyone can go back and listen, because the presentations this morning have really been top-notch and very exciting. So with that, I want to talk about newborn screening. for sickle cell disease. We may have been talking about this for quite some time now, but because it is not yet universally being implemented, we continue to talk about it until we get it done. That every child in Africa, in high burden countries in Africa, when they are born, just like children elsewhere, they will be screened, and they can, begin to look after them as early as 3 months of age, just like Ofakunwi said. In fact, that is quite new to me, that even at 3 months, somebody would have had acute splenic sequestration, and we would not imagine it. So we want to really, have all of this available. So if I can share my screen, please, if it is possible for me to
Yes,
share
ma,
my
you
screen.
can. Please go ahead.
Okay.
Yes, you can.
Okay. Thank you very much. Okay. Slideshow. Start from the beginning. Okay. Let me move this out. I think I should remove the, yeah. Right. So my name is Obi Nodu. I'm a professor of hematology and blood transfusion at the University of Abuja. And I'm going to use, I'm basically going to answer a number of questions. What is newborn screening? Why is it important? What are the protocols for newborn screening? How do you set it up? How do you track babies? How do you take care of babies that are detected? What kind of delivery systems are we talking about or are practicable in a situation? What are the challenges to newborn screening? What are the possible alternatives? And how can we go beyond pilot projects to national newborn screening programs? And what must we do now as a result of all of this talk that we've been having over the years? So that is going to be my outline and the presentation. Okay, so like we all know, sickle cell disease is the commonest genetic blood disorder known to man. And I've listened to people, for some years we used to talk about the 150,000 babies born in Nigeria, or 500. The data has changed. So it's very important that we refer now to the global burden of disease estimates to 2021 that shows that the number of people of sickle cell patients around the world, and then the data from Africa that is showing that majority of these babies are born in sub-Saharan Africa, where sickle cell disease is the leading cause of mortality in under 5s. Not only under 5s, but actually those 5 to 14 years, as well as in adults. And also to just listen, to see that the figures, have shown, changed somewhat, and now being driven by population growth. In these same countries, we have an explosion of population. We have, many people who are carriers, with carrier rates of up to 25% in most of the high burden countries. And these are the drivers, for the disease. And so there is an urgent need for universal newborn screening systems, and then which will give us increased access, to make the diagnosis early. And that presentation by Professor Maxwell was absolutely brilliant. He covered, all the grounds. And when you're hearing data like this, and then you start a screening program and you begin to see the statistics, it's really shocking, because over the past 4 years in the American Society of Hematology newborn screening program, which we have in Nigeria, in Abuja and in Kaduna, we have in Abuja, we have screened over 26,000 babies with sickle cell disease. Normally we screen up to 6 weeks of age, and we aim to enroll them by 3 months max. We have found that 15 out of the 319 babies that we detected have died. And mostly these are the ones who refuse intervention. And then 18 of them have had a blood transfusion, and 28 of the babies have been hospitalized. And this is telling, because you would think that, okay, all you needed to do was to identify the babies and everything will be okay. But we are finding certain challenges which we are working very hard to see what we can do about. And so evidence that was gathered mostly from the United States back in the early days of the cooperative trials shows that newborn screening saves lives. And when you identify babies with sickle cell disease and you give them penicillin prophylaxis, you give them pneumococcal vaccines, you give them hydroxyurea therapy, and then you institute surveillance for risk of stroke and treating with a blood transfusion. And as the studies in northern Nigeria have done, where that is not practical, you can even use hydroxyurea for both primary and secondary prevention of stroke. We see that it is important, and lives can be saved when the babies are identified early. And so how do we do this? What are the screening approaches to screening? So you will have more in-depth discussion of this in the Lancet Hematology, Lancet Commission for Hematology, where we did that section on newborn screening. So you have extensive discussion on newborn screening in that section of the Lancet Hematology. But for here, I just want to emphasize that the type of screening is a neonatal screening. That is when you can save the most lives, when you find them in the neonatal period. And the available technology is a heel stick. And then, of course, we have a variety of machines that can be used. Professor Maxwell has told us about the methods, the isoelectric focusing, HPLC, capillary electrophoresis, mostly for the Francophone countries, and mass spectrometry. So this is very expensive, but we know that in a number of African countries, we have mass spectrometry, which is being used in identification of infectious organisms. And so when we talk about integration, if you don't have HPLC, IEFs, capillary electrophoresis, but your organization has a mass spec, then we can even think about using that, piggybacking on that infectious program, infectious disease program to do newborn screening. And of course, in recent times, we have the point of care test, which we are looking at critically to see how we can use. Professor Maxwell has talked about it, all of the methods, we have those, the labor intensive, the ones that extensive expertise is needed. And then the cost of these, all of these have fully been described. And so this is just to reiterate what he has said before. But like he said, just to emphasize, because we have had cases where we have used isoelectric focusing to identify babies with sickle cell disease. And some well-meaning healthcare worker will say, no, you cannot identify babies with sickle cell disease under 1 year of age. And then they will make the parents not to accept the diagnosis and to delay. And these delays have resulted in those morbidities and mortality that I pointed out earlier on. So cellulose acetate electrophoresis is not the diagnostic method for newborn screening. So let us be aware and not unteach people or give them well-intentioned but false information about their health status. And so he has talked about all of this as well. So I will leave it. How do we set up newborn screening programs? Because I noticed that a number of initiatives are coming up not only in Nigeria, different parts of Nigeria, but across Africa. So how do we set it up? In fact, I learned a lot, by my involvement in the American Society of Hematology Consortium for Newborn Screening Program, where we spent 2 years just developing the protocol. And that tells you that after the protocol is developed, we have to spend as much time in educating, training people to use the protocol, retraining them, because sometimes people feel that they now know and they can start doing things that are outside of the protocol. So that training is very important, and retraining is also very important. So, and it's also very important that because nobody is funding newborn screening yet, nobody is really funding sickle cellers yet, that we don't set out to create silos, but that we integrate whatever we are doing into existing public health programs. And this is the only way that we can guarantee or ensure sustainability. So it's important whether the programs are immunization clinics, such as what we are doing in Nigeria, whether it's maternal to child care, clinics or programs, whether it's the malaria control program, or whether it's the prevention of maternal to child transmission of HIV program. All of these, in fact, can be integrated. We piggyback on what is working, and then, we introduce newborn screening. So the protocol that we developed looked at where the samples will be collected, when the samples will be collected. Is it at birth, at participating institutions? Is it at postnatal clinic, usually at 2 weeks and 6 weeks? Is it at first immunization? So you have to look, and then we are also now asking stakeholders what they think about the care that we want, this program that we want. We want to hear from the stakeholders, and they are telling us that the immunization clinic is okay, as a place to collect the samples. Then the screening laboratory, we have to determine which laboratory has the capacity to do this, mostly in terms of personnel and resources. So, and then we have to determine the test to be used. For instance, Nigeria had invested in HPLC, BioRad HPLC newborn variant machines, 6 of them, very expensive machines. But we had them, but we were not able to sustain the use of that expensive equipment. So we have to determine what equipment do we have. And honestly, if we don't have the money to buy the expensive equipment, Professor Maxwell has told you of innovative alternatives that we have discovered that we can equally use. And we have actually gone around the whole country, where the sickle cell centers are. And we have been able to see that you don't need rocket science to start newborn screening. You can actually start where you are with those innovative point of care tests. Then we have to find out what happens to the result. We are finding out in our program that when there are delays in communicating the result to the mothers, there's this phenomenon which I best describe as birth migration, the practice of birth migration in Africa, where mothers go to the villages or to their homesteads to have babies under the care of an older family relative. And then afterwards, they go back to where they live. So if you've done newborn screening and you were waiting for long, by the time you get the result, they have gone. So it's important that we set time, for, taking the result back to the mothers, so that they will be able to have it before they go back to the city. So what happens to the result? The result should be communicated not over the phone for a positive result, but should be communicated in person. And then we also find out that the healthcare workers, the in charges in the primary healthcare center, they have a mechanism for following up babies in immunization. So we need to work with them. And lately, we have even gone beyond that to involve the community, like the priest or the chief of the village or the pastor, to see how we can ensure that we are getting adequate follow-up of the babies. So what happens to the result? The person responsible for the parental follow-up and scheduling clinic, all of these things have to be decided, and people trained, accordingly. And then, of course, the issue of confirmatory testing. Usually, in order to ensure that we have the right baby. So when the result is communicated, they are invited, to have a sample taken. That is a sample that is taken for confirmatory testing. And so when you have that confirmatory testing, then you now bring the baby into care. So the clinical network for follow-up and care of screen-detected babies. Initially, in a setting, we thought that all the babies should come to the teaching hospital, but we're getting some pushback from the parents from that. So we are now deciding to look at the primary healthcare centers with the highest number of identified babies and to train the primary healthcare workers to give health maintenance while registering the babies in the teaching hospital and establishing a mechanism for immediate referral, of babies when they have when they develop acute complications. Of course, the drugs and the immunization, we have to ensure, that is available. Fortunately, the pneumococcal vaccine is available as part of MPI, in most African countries. And then the data management workflow. All of these things are identified, but somebody has to be responsible for the program and be responsible for the quality control of the program. I know that I'm speaking to an African audience, so I'm just going to say that the Federal Ministry of Health has a policy for newborn screening. This was developed in 2012, 2013. It has also been revised recently, and that protocol looks again, at the sample collection, the movement and transport of the samples, the counseling, who is going to counsel the babies with abnormal results. And it is not just the babies that have the sickle cell disease, but also those who have the trait. More importantly, those who have the trait, they have to understand what the implication of this is. Yesterday, somebody called me, a young mentee called me and said, oh, I have some friends, they want to get married, they are AS. Please, I need an appointment to talk. He's trying to get an appointment for me to speak with. I said, well, if they know their status and they want to get married, I won't spend my time on that. Let them go and see the genetic counselor. You understand? So these are the people who are driving the sickle cell. These are the people who are driving it, because we know what to do. For 100 years, we know what to do, and we are still getting sickle cell. Okay, so the counseling, has to be for those who have the trait as well, the follow-up, and then what should be captured in the database. And we have to be able to follow up these people. Then extensive training and retraining on the protocol is essential for all stakeholders involved in NBS, and then M&E mechanisms, established, so that the program has adequate quality assurance. So the federal government has, and then the Consortium for Newborn Screening, which is in 7 African countries, has a very detailed protocol. Every aspect of the screening process, the follow-up, and the care, of the babies have been dealt with in the protocol. So the consortium is in Liberia, in Ghana, Nigeria, Zambia, Kenya, Tanzania, and Uganda. So these 5 African countries. So so it's not just enough to talk about newborn screening. We have to ensure early therapeutic intervention. So we did penicillin, daily penicillin up to age of 5, anti-malarials. Make sure that they're fully vaccinated. Of course, hydroxyurea from 9 months, nutrition support. And this is why I've started talking to government officials, in the Ministry of Health. Okay, so you have a nutrition program. Can patients with sickle cell disease, be beneficiaries of that nutrition program? Then crisis management, just like we're beginning to address now, stroke prevention with transcranial Doppler ultrasound. I hope that one day we'll be able to have handheld TCD devices that we can administer at that primary healthcare level to detect these children who have risk of stroke. And of course, to have adequate transfusion support where possible, or a hydroxyurea, as we are trying to scale up. The most important aspect of this comprehensive care is the caregiver education. Like Professor Fakumi just shared with us, the mothers need to be taught how to look after the patients with sickle cell disease, how to detect, how to take the baby's temperature, how to feel the spleen, palpate the spleen, and what to do if there is any complication. Okay, I kind of put this just to remind myself that we are not working alone. We are working out of the Sickle Cell Support Society of Nigeria. We are working out of 25 clinical centers within the country. All that we are doing in terms of the point of care tests, implementation science or newborns, we are doing across these 25 centers. And this is a picture of when in 2019, when we did that first study on point of care test, and it was a public presentation with the Federal Ministry of Health and Silver Lake Laboratories. So I'll very quickly talk about CONSAT because you may have heard me. That's an initiative to enhance newborn screening where the American Society of Hematology set out to demonstrate with African hematologists the effectiveness of newborn screening and early therapeutic interventions for babies with sickle cell disease in sub-Saharan Africa. Why was this necessary? Because there had been a number of pilot programs that had not progressed beyond pilots. Like the oldest of it is almost like 20 years now in Ghana, but it hasn't achieved national spread. And we have all across Africa different pilot such programs. And you can see the white paper that was done, and then empowering newborn screening that has been done. These are really looking at details as well as the Lancet Hematology. Please, if you're interested in newborn screening, get some of these papers and read them because it will help you to appreciate what the challenges are and what is happening in detail, in each African country. So why have these programs not progressed beyond the pilot? I think Professor Maxwell alluded to some of it, but it's just, the sheer high cost of standard screening equipment and reagents. The fact that you can be doing a program for 4 years using a particular method, and you still need some training to be able to. It's, maybe you have 1 or 2 or 3 experts in the world who can really tell. So we need, it requires skilled personnel. It requires a stable electricity supply. And then we have the challenges of supply chain logistics. So many components are required for you to do isoelectric focusing. And then the African government, as was seen in the progress in implementation of the African region sickle cell strategy, when an analysis of the level of implementation was done, the countries don't have budgetary allocation for sickle cell disease. So how can they do newborn screening? Until they do that, we will still be begging, maybe some program or not sustainable, here and there. And then we have non-integration of pilot programs into existing public health services. This is very important. And so, based on that, excuse me. I'm sorry. So there are the CONSA initiative is one initiative to enhance newborn screening. The other one is based on the work that we have done over the years, both in Nigeria and currently with the Sickle Pan-African Research Consortium, where we were able to demonstrate the high sensitivity, specificity of point of care tests in identifying individuals with sickle cell disease as well as normal and the trait using a sickle scan and hemotype SC, and demonstrating their use in immunization clinics in multiple.
Sorry, ma'am. Maybe you should take a little break, take water, and then you'll be fine. Sorry.
Yeah, thank you very much. Okay, so we were able to demonstrate the use of these methods, in immunization clinics. And then, so these are, we publish these variously, and I think we got a lot of reviews and interest internationally from those studies. But we also noticed, just like Professor Maxwell had said, that when you're using the hemotype SC in a busy immunization clinic, there are certain constraints, because it needs 10 minutes to run. And just like he said, the Sickle Pan-African Research Consortium is looking at an implementation. In fact, we have concluded we're about to look at the results now. So we are conducting or rounding up an implementation science project where we have used DBS point of care test, DBS being a sample collection device used in public health. And we wanted to use it to see if we can scale up newborn screening across our 6 countries. The 6 countries being those ones, for the Sickle Pan-African Research Consortium of Ghana, Mali, Nigeria, Uganda, Tanzania, Zam. These are the countries. So we have looked at the performance characteristics of DBS point of care tests, against the standard isoelectric focusing HPLC. We have used it the DBS point of care test to screen for babies, 7,500 babies in our 6 countries within a very short space of time. And then we have examined the inner and outer context of these, how we are going to offer these services, looking at the different stakeholders, the caregivers, the conducting in-depth interviews with policymakers and administrators, and then just examining the parents and caregivers, and also individuals with sickle cell disease and the healthcare workers themselves. And we've been able to get valuable insights that will actually help us in the rolling out of a newborn screening program. So these are very exciting periods. So the most important thing that we are noticing, both from the CONSA and then from the SPARCO newborn screening program, is that it is, identifying the babies, following them up is crucial. Post-test counseling is very important, enrolling them into care so that they can start immediate prophylaxis, penicillin prophylaxis or anti-infection prophylaxis, confirmatory testing, the genetic counseling, the education of the parents and the healthcare workers, and then linkage of into pediatric care so that they will be able to, and where the mothers are saying, please leave us in the primary healthcare centers, we have to train those primary healthcare workers how to give health maintenance. Then we are also looking carefully at what to do with parents who are not willing to accept results, because they say, oh, our baby is normal, this baby is normal. Why would I go to a busy pediatric clinic, with my baby that looks normal? Baby will look normal in the first 6 months of life. So we feel that education, even upstream, is quite important during the antenatal, and then to have standardized material that we use, for this education. Then the other one is what to do with those who are lost to follow up, and the difficulty in tracking babies, where you don't have house address. So we are looking at some of these things and we are trying to see. I know that Ghana has the GIS. Ghana, the way they enumerate the houses, the addresses are more precise. But here in Nigeria, we have like, okay, so you go, that house beside a big tree, in some place. So that's how some people describe. So we think that we have to find very good ways of noting the addresses, this very descriptive addresses. We have to look at that, and then also get the numbers of the community, maybe the pastor or the imam or the chief, in addition to the phone number of the woman, so that we can use it to trace those babies. So we are also designing information, the materials, to be shared both via local social media and to give to the parent. And I must confess that I acknowledge that the BMS, where CONSA has worked with Bristol, my BMS, my Squid company, to develop a job aid and materials that we are actually using to help us, with this education. We need to generate awareness of newborn screening services, and then to create demand for it by patients. So we are working very closely with the media now to say, okay, these services are available, but it's not enough for you to treat. You must bring your baby back for follow-up, and then to just let them know about sickle cell disease so that they join us in being advocates, for newborn screening. And then we feel that sensitization in pregnancy is very important. Professor Maxwell has already talked about, these innovative techniques, have been used, to try and identify babies. So you see where the people live. This is where the people are living in such rural areas. And this is the map of Nigeria from, the very intensely purple and pink areas are those with very, high prevalence of sickle cell disease. So you can see that some of these, the lighter ones are where you have low prevalence. So we have to just keep working at it, keeping an eye on this map until we get it all covered. So we feel that these easy-to-use point-of-care screening tests can be implemented in multiple primary healthcare settings alongside immunizations without substantial investment in equipment. So we have to train people to offer these services, and we have to train them. You know, the most important thing is to collect the blood properly. They're using the DBS. So multi-stakeholder engagement is necessary. So we have the public health practitioners. You know, these people haven't come on board yet because there is no major funder. But I'm certain that as soon as the funding increases, we have the public health people coming in, because this is not the thing for clinicians. You understand? So they will come in. I hope that they will come in. And then, of course, the sickle cell NGOs, we are working hand in hand with the media, with the clinical centers and the pharma, and then the parents, the caregivers, and the community. The sickle cell, the Ministry of Education is important, the funders, and then the Ministry of Health and the major NGOs. So what are the lessons that we have learned? The low uptake of enrollment following screening has been a major source of concern for us. Then the loss of follow-up is a major setback on newborn screening, and we must see how to tackle the loss to follow-up. The denial of fuel by the denial of mothers, you know, the results by mothers. So there's need for massive sensitization of the population to accept screening and follow up using standardized material. Then, just like I said in the other slide, we have to work with the community leaders. We have to integrate newborn screening into existing health programs to enhance the reach and effectiveness of these screening initiatives. What India has done after the Global Congress in Sickle Cell Disease, they have up to 15 companies that are manufacturing different point of care tests. They've really gone overboard, and they are making their point of care tests locally, and that is what we need to do as well. You know, so the take-home message is that, well, we all know that sickle cell disease is a genetic blood disorder in high prevalence in sub-Saharan Africa, leading to early mortality. Please, if you want to quote anything, go to that global burden of disease estimate. These are the new figures that we should be looking at. And then we'll also refer to the Lancet Hematology Commission in sickle cell disease, where we have recommendations on what to do over the next few years to achieve universal newborn screening. You know, universal, that is globally. And then newborn screening with evidence-based intervention saves the lives of individuals with sickle cell disease. But we cannot rely on donors. Countries have to put budgetary allocation, and this is at all levels, at the federal level, at the state level, and at the district level. We have to put this demand on our people, you know, on the government to screen babies for sickle cell disease. This is what we need to do if we achieve universal newborn screening in our high-burden countries. Then we have to think of how to do this. For me, I think it's got to be a combination of standard methods in reference laboratories, and then you deploy point-of-care tests for remote areas. This is what may be necessary to achieve universal newborn screening in African countries. Then when I think of those mothers that just come once and you just have one opportunity to do the test, and what Professor Maxwell just said, I think that innovative molecular diagnostic point of care tests should be developed so that if you have just one chance, right, to collect a blood sample from a baby, that will be a diagnostic sample, and that might also give you some information to prognosticate and for personalized medicine. I'm thinking into the future. So we have to integrate this into existing public health programs to overcome the current challenges with follow-up. So I want to acknowledge the environment under which we are working, the very conducive environment for research, at the University of Abuja, the work we are doing with the Federal Ministry of Health, the funding by the NIH, whether it's in terms of the funding for the registry study, funding for newborn screening study, or the training grants, and then of course the American Society of Hematology, all the health officials and the stakeholders who have worked with us in communities across our 6 African countries to implement the newborn screening program. I want to acknowledge, all my colleagues, in SPACO and SESTA, in SPACNet, and just want to thank all of you. Thank you very much.
Thank you so much, Prof, for that excellent presentation. Excellent presentation. So we'll take few questions, though we are almost using up our time for break. We'll just take few questions, and then we encourage people to please post your questions on the chat box or raise your hands if you want to say them directly. We just take 2 questions from people who raise their hands, and then others who can take via chats. Thank you so much, Prof, for that presentation.
Thank you.
Okay.
Apologies for. Okay.
Not at all.
Professor
Yes,
Aisha.
Professor Aisha. Yes.
Professor Aisha, you have the floor. Professor Aisha, you have the floor.
Okay, so Dr. Kelechi, please go ahead. You have the floor.
Good morning, Ma. Thank you, Ma, for your presentation. I just want to confirm about the policy by the federal government for newborn screening. The year, I didn't get the year, and I want to also ask the level of the implementation of this policy currently in Nigeria.
Thank you very much. It was developed in 2012, 2013, and it was revised in 2022. But Dr. Layo told me that this year they have been able to, for the first time, get newborn screening into the budget. Yeah. So that might be able to do some workshop, maybe like 10 for the whole country. But it's a starting point. So we are really grateful for that. Professor Aisha, maybe you're muted.
Yes, good afternoon.
Yes.
Good afternoon, Ma.
Good afternoon.
Good afternoon, everybody. Thank you very much for the very eloquent presentation. Newborn screening, I think with your with all that you have been doing, we thank you so much. It's beginning to become a household name, and many people are keen into the screening. We haven't had much problem getting people to consent. So I must commend you, and we thank you very much for the leadership. Thank you.
Well done.
Thank you so much, Prof.
Well done. Thank you so much for that encouraging. So what about the follow-up? What about the follow-up?
Yes.
Because that's where the rubber meets the road. Yeah.
Yes, I think there is a bit of, would I say, fall back on the follow-up. Sometimes people are not, because, especially we have the RAs are registrars and nurses, and sometimes they are rotated, they are not there. So to get somebody else to start and things like that, a bit of logistic problems. But I think we are on it, and our nurse RA is doing well on that. She's feeding on the red cap, even though she was not able to do that for a while because of she couldn't get the password, so she had problems. But I think she sorted that out.
Okay.
She's on the platform. You can confirm.
Okay.
Okay.
Okay. No. I was thinking about the public health aspect of the newborn screening program. You know, because I know that Kano has started, and I want to acknowledge the presence of Professor Fenella Kekam, who is a world authority on a screening, a TCD. So, Prof, I hope you've heard me. I'm hoping that we will have a point of care screening, TCD screening device one of these days, because that is what may be most suitable, you know, for us, you know, in Africa. You understand? If there's resistance to going to the big teaching hospitals by the mothers, then we have to take these services where they are. You know, some kind of point of care, you know, handheld, not electric, battery operated, you know, to help with the screening to detect those who have risk of stroke. It's my wish list. Yes.
I totally agree. I think what we probably need to do is to really think about an economic assessment of the point of care. And I really took your point about the mothers may not be having their babies and staying where they had the baby. They may live somewhere else with their husband's family. There are lots of practical and quite expensive problems to be solved, but you know, I really admire you all for really working so hard on this.
Thank you very much for your encouragement. I'm thrilled that you attended. Thank you.
Yes. Ma, please have a question, ma.
Okay. Yes.
My name is Yusuf Mukhtar from Research Center, Brennan KB, FMC Brennan KB, working with Dr. Garba Kengiwa. We have conducted our newborn screening baby perfectly and submit our data. But you talk about the follow-up, ma?
Yes.
On the platform for the screening, the red cap.
Yes.
So for we to continue with the follow-up, I don't know how we are going to go about that.
Okay. Okay. Yes. So, but are the babies coming? Are they coming back? Are you able to trace them? Are you able to trace the babies after the screening?
Yes, we are able to train, because after the training, you know, there's another program where we had a focus group discussion.
Yes.
We call on them and they turn up. So if we want to get access to them, we have a form, a platform that we can get access to them.
Okay.
But the follow-up, that's what we want to know much, how we can do the follow-up.
Okay. So okay. So what I would suggest, and I think what we have tried to do, we've made provision to treat the cancer baby, the SparkNet, the NBS, Sparko NBS babies, because there are not so many, the same as we are treating the cancer babies. So we provide for their penicillin, right? And the folic acid, and then the test, we do the same. So just liaise with Ruben. You understand? Okay, so Ruben, Ruben and Dr. Patrick. Yes, Patrick. We ensure that we get the penicillin to the babies who are back. You know, we are able to bring them back into follow-up after that identification. You understand? And then so the cancer is for 5 years, but we do this alongside and see how we can get those same things as we're having here at CESTA to them until the country kicks in, you know, with the national program. So we'll do that for all the babies that are identified in the Sparko newborn screening program. There are not many of them. Dr. Patrick, you've heard me?
Yes,
Dr. Patrick.
Yes,
Yeah, okay, good. So we have to link up with the sites and make sure that they are all followed up. It's very important. Okay. Dr. Timothy, I saw your hand
Thank you
up
very much.
earlier. Yes. Dr. Timothy Ekwere, I saw your hand up earlier. Or has he gone? Dr. Timothy, if you can hear me, please unmute, you have the floor. And I can see NS from Novartis. NS, you're welcome. So we'll be coming to you to see how Novartis can support a newborn screening program. Okay.
Thank you, Ma. Thank you.
Okay. All right. So I don't know if we have answered all the questions.
Yes.
So I turn it over to you.
Dr.
Yes.
Yes, ma'am. Unless Dr. Timothy wants to say something. I saw his hand and he was ready to speak. So, Dr. Timothy, please, you have the floor before we move to the next presenter.
Maybe he's muted. Okay, so I want to thank all of you. I want to thank you for listening, and we appreciate your collaboration, anticipated collaboration, if we're not already collaborating. Thank you.
Thank you so much, Mark. Our next presenter will be Professor Brown. Professor Brown, I don't know if you're on the call. If you are, please, I just saw you log in and out. So if Professor Brown is still getting ready, Dr. Issa would go next. So we've taken in, we wanted to take like 5 minutes break, but the question and answer section, got so engaging and our time is, a little bit fast spent. So we'll move to the next presenter. Dr. Issa, are you ready to go next? Hello, Dr. Issa. You're muted if you're speaking.
Okay.
Yeah, we can hear you now.
Okay, I'm trying to share my slide.
Are you able to share your screen?
Yeah, that is what I'm trying to do now.
Okay, so just to introduce Dr. Issa is a consultant hematologist.
Hello. Can you hear me? Hello.
We can hear
Ready,
you.
please go ahead.
Okay.
I was introducing my network went off. I was saying that you are a consultant hematologist, an associate professor in the Department of Hematology and Blood Transfusion, University of Abuja Teaching Hospital, and you'll be talking to us on health maintenance and preventive therapy.
Okay.
So please go
Thank
ahead.
you. Okay.
Thank you.
Thank you, Ruben, for that introduction. Good afternoon, everyone. So Sorry, my slides are not moving. I don't know. Okay, it's moving. So he has done some introduction, just one or two more disclosures. The source of the material I'm using for this presentation is from the Standard of Care for Sickle Cell Disease in Sub-Saharan Africa, which was developed by the Standard of Care Working Group of SPACO-1. And this was chaired by the late Professor Kwaku Ohene in Frimpong, and it had members, it has members from Ghana, Nigeria, and Tanzania. The aim of this protocol was to develop and implement and evaluate a resource-based multi-level guidelines for management of sickle cell disease in sub-Saharan Africa in order to standardize the care of individuals with sickle cell disease. So this is the material, the source of the material that I'll be using. So the presentation is going to follow this outline, talking about the various measures of health maintenance. So we all know that sickle cell disease is a lifelong condition associated with complications involving every organ system, especially if it is not well managed. There are several simple and inexpensive measures, or if they are well observed, that are known to reduce or prevent these complications and maintain the patient in a relatively good health. Patients and their caregivers need to understand the disease very well, and also their cooperation is very important in managing sickle cell disease and in health maintenance. So one of the very important measure in health maintenance is to organize clinics and supportive groups. You know, all patients with sickle cell disease need to enroll at the nearest sickle cell disease clinic and attend the clinic regularly on their clinic appointment dates. This is very key and important, and it serves as a platform of maintaining contact with this patient and continually engaging with them. And this is the platform in which, you know, the chronic, especially the chronic complications are proactively managed, you know, by way of screening for these chronic complications such as chronic renal disease, pulmonary complications, the bone and musculoskeletal complications. When they are coming to these clinics, these chronic complications can be proactively, detected or screened with the aim of detecting them early and intervening. So clinic attendance is very important, but unfortunately, there are only few sickle cell clinics that are available. And these clinics are mainly available in the city centers, and that brings us to the need of really educating other healthcare providers at the other lower levels of healthcare, like the secondary healthcare facilities and primary healthcare facilities. This is necessary. By the time we have patients enrolled in those lower facilities, at least they will be able to provide education, be able to manage the complications, and those that they cannot manage, they will easily, they will quickly transfer them or refer them to the tertiary hospitals. Then another measure again, apart from the clinic, which is more formal, another way to maintain contact with this patient is to link the patient to patient support groups, or encourage them to set up support groups if there are none available to them. These support groups are also very important, even though they are informal, but as they meet with each other, they will be sharing their problems and, be having some assistance even from among themselves. And this support group should be structured, and a composition should be a peer group. If maybe parents of newborn babies or parents of sickle cell disease patients can come together to form a support group, or teenagers or adolescents or patients that have sickle cell disease can come together. This will help them and give them the freedom of expression, whenever they meet. And the support groups should have rules and regulation. They should have leaders, and they should have ground rules. Whenever they meet, their meeting should be regular, simple, and short, in order to encourage subsequent attendance. Meeting venues should be accessible, especially if they are meeting physically. And if they are meeting virtually, it should be a well-managed social or virtual platform. Then the groups need to have a healthcare provider or professional as a patron or as an advisor, for oversight, because in as much as these groups are important, they provide some support to the patients. Sometimes there could be avenues of spreading false or misleading information. So if there are professionals or healthcare providers that attend their meetings once in a while, or that are on the platform, and they are able to look at the conversations that are going on the platform regularly, they can help correct some misinformation or misleading conversations that are going on in the group. These support groups can also be formalized or even registered with the Corporate Affairs Commission. Then another health maintenance measure is education and psychological support. Regular education and counseling about sickle cell disease should be done at every opportunity or contact. So I mentioned earlier, as you come to the clinic, every clinic visit should be considered as an opportunity for continued education and counseling. And counseling should be done, or education should be done using standard and verified materials with contents that are factual. The mode of delivery can be through the use of brochures, videos, or skits, or apps, like we do in our clinic here in University of Abuja. As the patients wait to see the doctors in the consulting room, there is a lobby where they sit down to watch educative materials on sickle cell disease. This is something that can be done in every clinic, and the patients, from their feedback, has found this very, very interesting and useful to them. But patients should be prompted during such discussion and given opportunity to ask questions, to share their problems and experience. And then while educating them, it is also important to encourage them to acquire formal education, to increase their chances and opportunities of having gainful gainful employment for their livelihood. Because of their condition, we know that they cannot be engaged in some artisan work like that are available, like carpentry, that are so stressful. So they should be encouraged, to acquire education in order to increase their chances of getting livelihood. They should also be encouraged to participate in social activities and such as support groups, platforms, and sports. Infection prevention is also a very important health maintenance measure. There are general infection control measures, such as being able to detect fever early, especially when it is getting very high, above 38 degrees centigrade. Patients should be encouraged to own and learn how to use a thermometer. For the children, the auxiliary temperatures should be used and not the oral type. And there are so many thermometers that are available in the market that are simple to use. We have the digital thermometers, and then even the laser non-contact thermometers. So the patients or health caregivers should be encouraged to get this and to learn how to use it in order to be able to objectively detect very high-grade fevers on time and present themselves to the hospital for management. Then another a very important infection control measure is vaccination against Haemophilus or encapsulated bacteria, which these patients are prone to. As we had earlier, they have hyposplenism, and as they grow older, the spleen regresses and the splenic function is very, very low. And so they need to have prophylaxis against this encapsulated bacteria, such as pneumococcus, Haemophilus influenza type B, and meningococcus, as we had earlier. And they should, this is in addition to the regular vaccines that children under 5 years normally have. They should have the 13-valent pneumococcal vaccine series shortly after birth, and then the 23-valent pneumococcal vaccine at age 2, with the second dose at age 5. Oral penicillin prophylaxis should also be administered daily until the age of 5. And for some of them that have had serious invasive pneumococcal infection like pneumonia or meningitis, they are encouraged to even continue this oral penicillin even beyond age 5. Then prevention of malaria. Malaria chemoprophylaxis should be offered, especially in countries with high transmission of malaria. Almost all countries in sub-Saharan Africa, have malaria endemicity, and malaria prophylaxis should be given to them. In addition to this, they should be encouraged to sleep under insecticide-treated mosquito nets Residual indoor spraying to reduce malaria infection should also be encouraged. And also there should be good environmental hygiene, keeping their environment clean, cutting down grasses, avoiding stagnant waters around their environment. Then there is also need to actively prevent enteric gram-negative organisms such as Salmonella, E. coli, and Klebsiella. Basic hygiene such as hand washing also, they should be encouraged to be practicing that, and also food hygiene. And if immunization against Salmonella typhi is available, they are encouraged to also have that. Then nutrition is also very important, because they need this in order to make up for the ongoing hemolysis that is due to their condition. So there is need to perform examination to screen for nutritional deficiencies, such as weight measurement, the measurement of mid-arm circumference, or the head side or the head circumference. These are simple measurements that can be carried out in order to identify nutritional issues early enough for intervention. They should be encouraged to consume balanced diet. They need all the 6 classes of food, including water, right? They need water more than any other person. They should take a lot of water. They need carbohydrates, minerals, proteins, vitamins, fats, and oil. All the food classes, they need them, and they should be encouraged to take all classes of food. Though we know that food is expensive, the economy is hard, but there are very cheap foods, foodstuffs that are available. They should also take advantage of seasonal foods that come in season. We have the yam season, we have the mango season, granule season. They should take advantage of this and make sure that they are having a good balanced diet. And then for sickle cell, for folic acid supplementation too is very important, which is actually part of their routine medications. So growth and development monitoring, as I mentioned earlier, and regular checking of their weight, height, and length for babies who are under 3 years. There is recombinant length. Then head circumference up to 36 months of age, and use of age-appropriate growth charts for infants, children, and adolescents for early identification of suboptimal growth. However, it should be noted that there is usually reduced height and weight for sickle cell patients in comparison with their peers. However, sometimes they may have a catch-up growth. Then transitions of adolescent to adult care is also a very important health maintenance measure, because it has been observed that patients, after leaving or being discharged from their pediatric care, when they grow up, many of them, they drop out from clinic attendance because they are not properly transited into the adult care. So while they are attending the pediatric care or clinics, the preparation for transfer to adult care should be started early enough. And then there should be collaboration. At some point, there should be collaboration between the pediatrics and adult healthcare providers to facilitate an effective transition. Is known as a transition clinics. It can be established, where it is possible, so that the transition will be smooth. Transfer to adult care should be accompanied with comprehensive summary, including details about the sickle cell disease related complications which they might have developed, investigations that have been done, and the treatment they are on. Especially when there is no transition clinic. As they are moving to the adult clinic, there should be a comprehensive medical report to accompany them. Then genetics and reproductive counseling too is also another health maintenance measure. All patients should be counseled, and if possible by trained personnel. So centers need to train and retrain their personnel in genetic and reproductive counseling. Counseling environment should be friendly, and there should be empathy and also confidentiality. These are key virtues to observe, during counseling. Ensure a maximum comfort and minimum distraction in the room or in the place where counseling is taking place. Accurate and factual information should be provided about the disease, and the use of local language is encouraged in order to make sure that the patients clearly understand what is being said. And technical terminologies should be avoided. Encourage patients to have a reproductive plan, including knowing the hemoglobinopathy status of their partners. For females, they should be educated about contraception. They are actually free to use contraception, and there is no contraindication to use of contraception in sickle cell disease. And if they are planning to get pregnant, they should stop the use of hydroxyurea 3 months prior to conception, and documentation of pre-pregnancy baselines should be done before they become pregnant, so that whatever changes occur thereafter, can be well correlated with the baseline, and then the necessary action will be taken. If patients are undergoing iron chelation therapy, maybe possibly because of frequent transfusion, during pregnancy, this should continue, because we all know that the developing fetus need iron. The risks of pregnancy, associated with sickle cell disease, should be well discussed with the patient. Both the maternal and fetal risks should be discussed with them. And then there should be early referral to antenatal clinic for follow-up. There should be collaboration between the hematologists and the obstetricians. Then they also need to routine vitamins during the pregnancy. Folic acid is very important. And then even the iron, if they are not having iron overload. And then they should be given 75 milligram aspirin after 12 weeks to reduce risks of eclampsia. And then the mode of delivery should be well planned, because of the risks involved, especially the maternal risks. And the use of venous thromboembolism prophylaxis also should be considered during pregnancies. And then for patients who have been on opiate analgesics for management of pain, their babies, there should be an active, proactive assessment of opiate dependency and withdrawal syndrome in the infants that are going to be delivered. Then for male patients, encourage men with sickle cell disease to have reproductive plan and to decide whether to have children or not and the implications of doing that. And counsel and educate men with sickle cell disease about heritability of sickle cell disease. In fact, even the female patients should also be counseled right from the time they are even planning to marry. They should be told to watch out for the sickle cell trait in their intended partners. Then the other issue to consider in health maintenance is when patients are traveling. Patients should be encouraged to seek travel advice if they want to travel. They should receive all the offered immunizations that are relevant to the area to which they are traveling to. This includes live vaccines like yellow fever. Patients with sickle cell disease should receive malaria prophylaxis when traveling to malaria areas, endemic areas, in line with the general guidance for the area of travel. They should be advised to carry enough medications if they are staying long, because in some countries, they may not be able, or in some places they are traveling to, especially if they are going to rural areas, they may not be able to have access to their drugs in those environments. So they should carry enough medication, and also they will need to carry medical reports, especially if they are going to stay for a long time, so that they can present to healthcare facilities in that where they are visiting, if necessary. Then they should be advised to avoid stressful journeys, long hour journeys that would take 12 hours or even more. If possible, they can break these journeys into parts to avoid stress that would trigger them into having crisis. So in summary, we talked about healthcare maintenance measure, and this is very important in order to maintain the patient in relatively good health, in order to avoid acute complications and to also proactively watch out for or prevent chronic complications. Thank you.
Thank you so much, Dr. Isa, for that wonderful presentation. Thank you so much. So very quickly, if we have questions, we'll take them. We have some already on the chat box, but if you want to ask, we'll just take 2 again. And then after that, we'll take the last presentation. So while we wait for participants who want to ask questions, we'll take the ones on the chat box. So the first question, Dr. Isa says, why do we give prophylaxis for infection only up to 5 years? You want to take them all together? So I can ask the second one if you want to take them together. Yeah, so the second one is, what level of HB is optimal to reduce fetal waste in pregnancy? Okay.
Okay. So why do they have prophylaxis only up to 5 years? You know, I think the reason is because we expect that by the time they are beyond 5 years, they might have developed what is known as herd immunity, you know, and they are able to resist such infections. There may be other reasons, but I think this is one of the reasons why they need they may not need to continue with those prophylaxis, you know, after the age of 5, just like in the other normal children, you know. But actually, this has been is being debated, where especially for sickle cell disease, because we know that as they grow up, there's the spleen becomes a plastic and there's still hyposplenism. So the question is that why is it that they should not have chemoprophylaxis against those encapsulated bacteria? So there's some advocate that even oral penicillin should continue even beyond the age of 5. Then the adequate hemoglobin level that is needed in order to prevent fetal retardation, right? I'm not sure I got that question right.
Yes.
Is that the question?
Yes.
Okay.
Yes. In pregnancy, yes.
In pregnancy. Well, we know that it's not only the hemoglobin that matters. In fact, generally, the needs to all the other factors that the fetal, that the developing fetus needs, you know, they should be in place, because even when women have adequate hemoglobin, they can still have babies with fetal retardation. But I think this a safe hemoglobin will be to maintain their hemoglobin level above 10 grams per deciliter. But of course, they should also make sure that there is good nutrition and all the other supplements that they need, folic acid, you know, in order for the developing fetus to develop normally and without any problem.
So,
Okay, sir.
yeah,
So
yeah. So what I want to say is that since there are many PIs on the call, very senior people, if there's a question, it's not necessarily for the presenter. You understand? So if there's a question and other people want to chat, feel free to, because this is this one is for us.
okay. So yeah, Professor Brown, please, you have the floor.
Yes, thank you very much, and good afternoon, everyone. Good afternoon, Professor Nodu. Just to add to what Professor Issa had said, studies in the US between the ages of 2 months and 5 years, I mean, first, penicillin prophylaxis has been shown to reduce by 84% invasive pneumococcal disease, 84% reduction without penicillin. But studies have shown that beyond 5 years of age, there is no added protection by penicillin. Beyond 5 years of age, there is no added protection from invasive pneumococcal infections by penicillin. And that's why in the US, it is not given after the age of 5 years because it's not useful. But places like the UK and other places, they give it for life. Like he said, that's some controversies. But based on science, evidence, beyond 5 years, there is no added advantage in continuing penicillin V for the patients. Thank you.
Professor Brown, Professor Brown, you know what I'm thinking? Is the pediatricians are driving these studies. These studies have not been done in adult sickle cell patients.
Yes, ma'am.
It hasn't been done. So that's why you are leading a study on this subject so that we know exactly when to stop, if at all, because I don't think that the spleens are growing after 5 years of age. Do you understand? The spleens are not growing back. They have autosplenectomy.
Yes, ma'am.
So I don't see, I think because it's the pediatricians that are driving the studies and the adult hematologists have not been doing that. I wish that Adama were here because she has done some study on spleen function. And I think it's like, I don't think she did it only in children. So I think that this is something that we need to gather the evidence. Are we going to give for life? Are we going to stop at 5? If you know, and the reason.
Well, thank you, Prof. The reason I have stated that beyond 5 years, no other protection. There are just 2 indications for using it beyond 5 years. That is if a patient has evidence of an invasive pneumococcal disease, that is pneumococcal meningitis or sepsis or pneumonia. And then 2, patients who have surgical splenectomy. Those ones will have the penicillin for lifelong. And that's what I think we should do. Those are the 2 indications for lifelong penicillin. Apart from that, after 5 years, it's not really necessary.
I still think that we have to, that was something done in the US where the environment is different. We haven't done our own studies locally. You understand? We don't know what is going on in our own environment. So that's clearly something that we cannot take and implement based on other people's evidence. We have to find out if our own people are any less susceptible after the age of 5. You understand, to these infections.
Yes, the problem there is that since the NPI now gives penicillin prophylaxis from 6 weeks to all Nigerian children, pneumococcal vaccine. Like in the US where they give the vaccine and the penicillin, their current studies show that those primary strains that were in the vaccine, the serotypes, are not seen anymore. The pneumococcal disease has come down very low, and when it occurs, the strains are different from those which cause it, different from the vaccine strains. So your point is right, we need our evidence, but the problem is that it may be difficult conducting studies here or getting meaningful results. I have done one in which I use Bactec. It will be difficult getting meaningful results when the patients are already having the pneumococcal vaccine from 6 weeks and the patients. So it's only if you're going to be, you want to stop them from having this or that. And the question will be how ethical it is. But it's a very good point you have made. We can decide to say, okay, let our patients go on the penicillin V. One arm takes it, one arm doesn't take it because of the disagreements from maybe major sites, and then we see what happens. In the end, the challenge we have is our laboratories, because these are very, very volatile organisms. I did over 100 studies, 100 patients. I saw just only one strep pneumo, even with Bactec. So you will need, at best, the best PCR to be able to say, oh, this person had a pneumococcal infection. But with the antibiotic abuse, using blood agar that already contains antibiotics in our blood and antibiotic use, the inclusion and exclusion criteria will be so tight that it will be difficult to come up with any significant number of patients who have pneumococcal infection. Apart from the studies on ground ordinarily across Africa that showed rarity of the organism, but you know, the confounders, like I said, antibiotic abuse and all that. So, but one can consider it and look at it.
Yeah.
Thank you. Man.
What about looking at the immunity? You're looking at the level of immunity to, you know, is there a way? I know they were doing some such studies in the past, like in the 70s and 80s, the level of immunity to pneumococcal, you understand? So I don't know if that would be another way.
It's worth looking at it. I agree with you, man. It's worth looking at it.
Yeah.
So, Ruben, am I free to go on, or are we breaking?
Yes, please. We just have we will not take any breaks, sir. Sorry. We'll have one question from Professor Madu. He says, what do you think about the SCD of vasoprene what do you think about the use, of vasoprene in SCD, knowing that the previous trial in its use to avert stroke in sickle cell anemia was stopped as a result of excessive bleeds? So that's the last question. Then we'll move to your presentation, Prof. Dr. Issa, I don't know if you can respond to this. And then if you can, please go ahead and then you stop sharing. Thank you.
Okay. Well, I'm not aware of that study. As I said, my source of the material I use is the standard of care guideline, which I was part of it. We actually went through many studies, many guidelines, African and non-African guidelines, to make that standard of care. We did not come across that study, and maybe that is why we are still recommending the use of vasoprene in pregnancy.
Okay, thank you so much, sir. Thank you so much. I can see Dr. Fakurin's hands raised. Okay, please, you have just 1 minute. Then we can move to the next presentation.
All right, thank you. In addition to what Dr. Issa has just said, so you know that talking about the use of aspirin in pregnancy is actually something that is very important, that it must be used. The main thing is that sickle cell disease itself is an hypercoagulable condition. Likewise, pregnancy as well. So aspirin is actually very fundamental that it should be given so that it will help in that, and also even it helps to reduce the risk of preeclampsia in them. So regarding those with stroke, yes, meaning they have actually one risk factor of being sickle cell patient. But in pregnancy, there are actually two risk factors: the pregnancy itself, as well as the sickle cell disease. So it still is important in pregnancy. So, and from the studies that have been done, there's no increased risk of bleeding in pregnancy. So it can be in the other study, but for pregnancy, it's being used and it's very important.
Thank you very much, sir. Dr. Issa, please, can you stop sharing? And I would share the slide for Professor Brown. Thank you so much. Yeah, so Professor Brown is a professor of pediatrics in the Department of Pediatrics, College of Medicine, University of Ibadan. University College Hospital, Ibadan. He'll be talking to us on acute pain crisis in sickle cell disease. So I'll just share your screen now. Okay. Yeah. Professor Brian, if you can see my screen, please, you can go ahead.
Yes, so good afternoon, everyone. I apologize, I joined in the meeting late. Due to some other commitments in our College of Medicine. I'll be presenting acute pain crisis in sickle cell disease. Next slide, please. Next, yes. So by way of introduction, pain crises are common in sickle cell disease. They result from blockage of the microvasculature by sickle red blood cells. They are also called vaso-occlusive pain episodes, VOPE. And almost every part of the body can be affected. But the affected parts tend to vary with age. And usually, one of the very first symptoms that they manifest with is the hand-foot syndrome, which is dactylitis. The hands and the feet are swollen, and that starts from the age of 6 months up to the age of 24 months. Very often, the earliest manifestation of sickle cell disease. Occasionally, I've seen it in patients of the at 3 years of age, but it's very commonly the earliest manifestation of sickle cell disease. Next slide, please. Yes. So, what are the things that precipitate vaso-occlusive crisis or pain crisis? Now, these things are the same factors that precipitate other forms of crisis in sickle cell disease, and they include extremes of temperature, cold weather, or heat. Infections also are part of what can result in crisis, stress, hypoxia, and metabolic acidosis. And like I said before, these are not limited to precipitating VOC, but also precipitate other forms of crisis. Next slide, please. Now, what are the clinical features? They are myriads, but I'll just talk about, I see clinical features here. I'm focusing on the features of manifestations of vaso-occlusive crisis that result in pain. And the first one there is the hand-foot syndrome. They may also have abdominal pain from many causes, but from a VOC. And then they may have a severe VOC that may present like an acute abdomen. And that often results from occlusion of the mesenteric vessel. So mesenteric vascular occlusion can result in severe abdominal pain that mimics an acute abdomen. And sometimes a surgeon may go in for exploratory laparotomy only to discover that there's no obvious structural abnormality apart from ischemia. And that's why it is recommended that all children should be screened for sickle cell disease as early as possible. If the phenotypes are already known, the surgeon will interpret this acute abdomen, bearing in mind the possibility that this may be a complication of sickle cell disease. So start with the hand-foot swellings, and then acute abdominal pain, and then as they grow older, the bone pains come and take the preeminence. But other parts of the body, chest pain, the ribs, the spine, the extremities can be affected by painful crisis. Even the liver having what we call the hepatic crisis can also cause pain in them. And then usually VOC or pain crisis affect multiple parts of the body. All right, and that one we are differentiating them from osteomyelitis. We know that osteomyelitis can affect multiple bones at the same time, but more often it's just a single bone. So the multiplicity of sites of pain in sickle cell disease patients points more to a VOC. And also, usual VOCs do not last beyond 1 week. And it goes beyond 1 week, then one has to begin to think, could this be just for VOC, or could there have been a complication by acute osteomyelitis? All right, but that can come on, and that will manifest as pain persisting in spite of management that is given. Just for us to also note that VOC is not usually occurring, doesn't always occur on its own alone, but it may occur with other forms of crisis. You can have VOC and also have hyperhemolytic crisis or other forms of crisis. So these are called mixed crises. Next slide, please. So how do we manage them? The first thing is to evaluate for other causes of pain by beginning to treat pain. Pain is the most common symptom people have across the world, and it's not something that one should endure. So make effort to start. If somebody who is convulsing, stop that convulsion and then try and find out the underlying cause of the convulsion and treat. So here also, start plans to stop that pain as soon as possible, and recommend that within 30 minutes of triaging, within 30 minutes, any child or any adult with pain crisis should have commenced the use of an analgesic. Then we check for other causes of sickle cell related pain, not necessarily a VOC. For instance, cholecystitis causes abdominal pain, and that is from gallstones, cholelithiasis, and yet it is not a VOC. All right, so, and then there are other causes also, they are not related to sickle cell disease, they can also cause pain. Sometimes patients say they have a pain in their neck, and the tendency is to see pain in the neck and a stiff neck. The tendency is to say, oh, this is a VOC of the spine. Some have turned out to be meningitis. So in evaluating them, one has to look at thoroughly, manage the VOC, have an open mind, have an index of suspicion, perhaps it could be something else. And then in the pain of crisis, you want to know the characteristics of the pain, because that will determine what drug you give, whether it is dull, aching, whether it is peppery or irritant, or whether it is just a discomfort. All right, and then you also want to assess the intensity. When you have this pain in multiple parts of the body, the intensity may vary from one part to another. For instance, the pain in the right humerus or right upper arm may just be 5/10, 5 on the scale of 10, and then the pain on the left lower limb may be terrible, maybe 8 on a scale of 10. So one needs all this information to be able to treat us. And then one should also, as one assesses pain using assessment tools, which I will share very shortly. And then one should also assess the use of recent analgesic use. Have they used an opioid or not? Was the appropriate dose used or not? For instance, if your patient has been using an appropriate dose of an analgesic, and the pain is not being relieved, there's no use waiting endlessly or continuing that drug. The child will refer to you. So if the dose was low, then you can be increasing the dose of the drug. All right, you can be increasing the dose of the drug. So you need that information. You also need information from on what drug the patient uses, all right, that relieves the pain. Next slide, please. So we start with the investigations. Like I said, the first thing is try to treat that pain and then carry on with the rest of the evaluation on the child. So the investigations will depend on the presentation, but generally, their aim is to find out what precipitated this crisis or what probably precipitated the crisis, and if there are any coexistent morbidity in the child beyond the VOC. Full blood count is important in investigating them. The one problem with it is that usually WBC in sickle cell disease, there's leukocytosis. Even in the steady state, 20,000, 21,000 cells per cubic millimeter, leukocytosis in many of them in the steady state. And unfortunately, many medical officers or physicians who are not aware of this, a child comes in with pain, a pain crisis, they do a full blood count, and it shows leukocytosis. They go on and start giving antibiotics, even without any evidence. Even without evidence of infection anywhere else. All right, so but the evidence is important to help us in knowing if that in a plastic crisis, if it is there, or the WBC, will it require blood transfusion? EU creatinine is also important to know the basis. You know, sickle cell affect the kidneys. Very important in painful crisis. He has said that metabolic acidosis can precipitate pain crisis. So you want to be sure that this pain crisis wasn't caused by metabolic acidosis. If it is, then you can go on to correct it in order to relieve the crisis. Liver function tests are also very important. Like I said, pain crisis may be ischemia or occlusion of the vessels of the mesentery, but can also be hepatic crisis, acute hepatic circulation crisis. Again, the LFT again will show that. They also have hepatitis causing the pain and tenderness over the liver as abdominal pain crisis. Again, so the LFT are important. Then infections, blood stream from parasites, urine culture, and blood culture. All these are helpful in trying to find out the underlying cause of the VOC. Otherwise, you keep on treating symptoms and the underlying disease is there. So we'll go on now to look at pain assessment tools. Next slide. Now, pain assessment tools are so many, but I will pick just those, just three. The numeric pain assessment tool goes from 0 to 10, with 10 being the worst pain and 0 being absence of pain. This helps us because even in treating the child, in deciding the dose of the drug or what drug to give, it also assists you in knowing how to de-escalate. In other words, either take up the one drug or reduce the dose of the drug. Right? So that is important. This can be used mainly in adults, but in children from the age of 6 years and above who can be taught to learn this, can use the numeric pain rating scale. And most of my patients that are of primary school age, they have no need, and they will just tell you my pain is 8, my pain is 7, and you should be teaching the parents and teaching the children how to score those pain. The other scale on the right, the Wong-Baker Faces pain scale, is used predominantly for children. Again, it's used mainly for children from 5-6 years of age. The younger ones may not understand it very well, and it has a risk. For instance, if you check your sim right, the child is in tears. All right. So if you ask this parent, this child, point your finger at any of the faces that reflects or that's equivalent to the amount of pain that you are feeling. The child that is crying here, a child may have just mild pain, but he may point at 10, not because of the pain, but because he interprets it as he had promised to give me to tantalizer today, and you have cancelled it. So unhappiness can make them to misinterpret this pain, equating it with severity of the pain. Next slide, please. Now, this is the FLACC scale. It's used in pediatrics. Like I said, the adults is very easy. Pediatrics need specifications. The earlier scale I told you, along with many other scales in pediatrics, usually can be used by children who are 6 years of age or more. But for children who are younger, that's a challenge. So for children who are younger than 2 years of age, non-verbal children, that is those that cannot talk, you can use. And so even for older children, if they cannot talk, the FLACC scale can be done. It's just it assesses the face, the legs, the activity, their cry, and consolability. Each of these 5 parameters has a maximum of 2 points. So if you add them all, maximum point that child can have is a score of 10, which is severe pain. But I'm sure the details will remain there and can be shared later. Next slide, please. So how do you manage pain? The first is that fluid therapy is important. And so they're giving fluids at maintenance. For those who have who are not admitted, then you tell the parents how much fluid to take. It can be so the non-IV fluids or oral fluid management can be either pharmacologic or non-pharmacologic. And I will give all the details of all these later on. Again, treatment can be based on the previous analgesic use, previous side effects. Some people, when they use morphine, they itch terribly and they vomit terribly. All right. So if their past experience shows that if a particular analgesic doesn't work well for them, one may need to avoid that unless they have misunderstood what they're having. And then the associated symptoms will also assist in knowing how to manage pain in sickle cell disease individual, be they adults or children. This slide shows us the 2 main broad groups of managing pain in patients with sickle cell disease. On the box on the left, as I'm facing your device, are the pharmacological interventions, all right? And the goal is to use a multimodal approach to pain, effective pain management. And this can be done at home or in the emergency department if they had analgesics at home and there was no relief. And then for inpatient admission also, you can give them drugs for those that do not respond to drugs given on outpatient basis or with coexistent morbidity that requires admission. And then we ensure they have adequate hydration. Now, in the past, it was said that for VOC, the volume of fluid to be given to them would be either 1.5 maintenance or 2 maintenance. Excessive fluid. But studies have shown that these have not really made any difference. So what is recommended is just give them fluids at maintenance. On the right side are examples of non-pharmacological interventions. All right, and this includes things like using heat packs, physical therapy, auditory relaxation, cognitive therapy, and biofeedback, acupuncture, sleep hygiene, and then the use of incentive spirometry. That also is useful in the non-pharmacological intervention. Music therapy is very good. Distraction therapy is also very good. You know, even just merely watching the television also is a form of distraction therapy, and somehow may not be pain away totally, but at least it gives some form of relief. Next slide. Right, so in adults, WHO has this analgesic ladder, and its old initially was 3 steps on the ladder for all, both for children and for adults. But recently, well, not recently, a few years back, maybe 5, 6 years or so years ago, they separated them. For the adults, the 3 steps are there, and then for the children, you now have 2 steps. Now, the step 1 is mild pain, and you treat with non-opioid like acetaminophen or non-steroidal anti-inflammatory drugs, plus or minus adjuvant therapy. Adjuvants are things that also assist. Some are muscle relaxants, some are sedatives, some are useful in neuropathic pain, so that's step 1. If patient does not respond to NSAID, non-opioid drugs, Then you go to step 2. In step 2, you use the weak opioid. And weak opioids include things like codeine and DF118, which is a dihydroxycodeine. Again, you can also use adjuvant drugs, as I've mentioned. And then for severe pain, you will go and you use a strong opioid. For severe pain, you can still add an adjuvant therapy, all right, while managing the adults with pain. Just to note that more recently, the WHO is proposing a 4-step ladder. He has proposed a 4-step ladder. The 4th step on that ladder is intervention. So you have mild, moderate, severe, and then the intervention. That is the 4th step that I've added more recently. So let's go to the next slide. So this also shows the 3 steps used for adults for relief of pain in sickle cell patients in adults. Generally developed for patients with cancer, but applied and adopted by the sickle cell space. Next slide. All right, so pain management in children. Again, we follow the analgesic ladder by WHO, and it is a 2-step ladder. And the first step is the mild pain, where you use non-opioids like acetaminophen and ibuprofen. Sorry, the dose I wrote here is ibuprofen, 10 mg per kg per dose. It can be given 12 hourly or 6 hourly or 8 hourly. So you give 12 hourly, it's not responding, you can increase, you can shorten the interval, the dosage interval. All right, I'm going to correct and add that. WHO recommends the use of ibuprofen, all right, but we know that it's not as potent as the other NSAIDs like diclofenac. So for children that are big enough or that are old enough, diclofenac can be used for them. But for young children, it's ibuprofen. Then for moderate to severe pain, strong opioids are used. And these include things like morphine, which is the most common, oral morphine, which is the most common there, given every 4 hours. IV can also be given in many guidelines, like in British guidelines. They will say for severe pain, start, even in the US, start with IV morphine. But we know that IV morphine, one, not readily available in our setting, and 2, oral morphine is as good because morphine is one drug that can be absorbed from the mouth. Sublingual morphine, if you put the morphine under the tongue, within a few minutes, it's in the blood. So it's almost as good as IV, except in cases in which the person is vomiting and cannot tolerate anything in the mouth. Right? So we can see that the different stages. Now, drugs can be combined in managing. So you can be combining a non-opioid with an opioid. But what you cannot do is that you cannot combine 2 opioids. If the weak opioid is not working, then go to a strong opioid. All right, you don't combine a weak opioid and a strong opioid. Weak is not working, go to the strong opioid. It's not working well, then you begin to increase the dose, begin to escalate the dose until you get a good response. Ruben, my slide is off. My screen is not being shared anymore, so maybe I should try and share my screen from this end. I know he had told me he had some network challenges where he is. So let me see. Oh, Ruben, how far are you able to? Can you see my screen?
Yes, we can see it.
Okay, so let me just go and continue from where I stopped. All right, so you will see that the weak opioids are not used in children. And that was why the second step from the WHO that was removed, because second step is meant for weak opioids. And why is it not used in children like codeine and hydroxycodeine? The point is that morphine is a prodrug. And so codeine is a prodrug. When you take codeine, the liver metabolizes codeine and converts it to morphine. However, it's been shown that in children, its safety of the weak opioid, codeine or dihydrocodeine, there are safety and efficacy problems because of variabilities in that metabolism, in converting that codeine to morphine. Some will convert it to a very small extent and they have a low bioavailability. Others will convert it excessively, and in the end, the dose is so high, and there may be some complications from excessively high dose of morphine in the blood. So the weak opioids are no longer recommended for use in children. However, there are settings we know that you cannot use, that you don't have access to morphine very easily. They will not have pentazocine also to use with extreme caution. And then in that case, if all you have is hydroxycodeine, you get 1 then you may have to use it. But and hope that you will have some efficacy, appreciable efficacy from it. Now, these are other forms of treatments that are used in treating patients with sickle cell disease. And this one is the incentive spirometry. What does it do? Every patient with VOC must have an incentive spirometry. Why? When the VOC affects the bones, it can cause infarction in the bone and from the bone marrow. And from there, you can have fat embolism or any other form of embolism from the marrow of the long bones. And when that embolism goes up, then you may have some real problems. Again, 2, during painful crisis, some patients, because of the pain, either pain in their ribs, on the chest, they hypoventilate. And that hypoventilation has a tendency to lead on to atelectasis of the bases of the lungs. So the aim is when you give them incentive spirometry, the device is shown on the left, and then the child puts the mouth end, and the child blows the mouth end of the device. All right. And by doing that, he's expanding the lungs, ensuring that you don't have the lungs collapsing, you don't have atelectasis from hypoventilation due to pain that they have in people pain. Now, other issues, this should be my last slide, I think. For every patient with pain, we need to decide, do we need to admit them or not? Indeed, the ideal thing is that there should be a call number. So when a patient with pain has, pain, has pain at home, the parents have been trained on what to do, but sometimes they will be confused. They call a number, you tell them, okay, is there fever? There's no fever, then give them analgesic, give them this dose based on the child weight. Okay, and that will reduce how often they will come to the hospital and how often, also empowers the parents or caregivers to manage the children at home. But they are told when to come. Any child with VOC or anybody with VOC that had a VOC, first thing is to ask, is there a temperature? Because sepsis can kill sickle cell patients very, very rapidly. If there's no fever, then we'll say take analgesics. If there's fever, take analgesics, but come and see the doctor. Hydroxyurea is a long-term benefit, by increasing hemoglobin F. In the long run, it reduces the severity of the disease and therefore the frequency of the crisis, the pain crisis that they may have. And finally, one has to look out for the underlying cause, and then you treat that underlying cause that precipitated the VOC. I thank you for your attention.
So thank you so much, Prof, for that excellent presentation. I apologize for jumping out of the meeting. My network went off, so I apologize. It's an excellent presentation, and I'm sure many of us have gained from this presentation. We have questions on the chat box, but people who want to, unmute themselves and ask questions should please go ahead. Raise your hands, and then we'll take that first before we go to the ones in the chat box. Okay, so while we wait for people to ask questions, we have the first one in the chat box. Hello, Prof.
Yes, okay, so the first I can see in the chat box here is, what do you think about the use of Vasopressin in sickle cell disease? Okay, that was what was handled by Dr. Issa. So let me go on to the next. Is there a role for vitamin D supplementation in sickle cell disease? Well, it is not standard of care. It's been shown that patients with sickle cell disease, especially when they have a VOC, the vitamin D level in them is lower than when they are well. And if you compare vitamin D levels in those with hemoglobin AA persons with sickle cell disease, the vitamin D is also lower in patients who have sickle cell disease. But people have tried giving vitamin D as an intervention, and it didn't seem to have changed or reduced the frequency of the crisis. So that, in theory, it should give us a result. But in practice, it hasn't. So it is not standard of care. But since it is not harmful, as long as it's not taken in any excessive measure, people can take it, but it's not standard of care in treating. Maybe one day we may have a larger study that may show how useful it is, and then it may be included in the guidelines. Good day, please. We need all the presentations. Ruben will handle all that.
Yes, so let me just read another one, Prof. He said, Professor Brown, if there is money for one test in a patient with VOC, what would it be? Just for one test.
Pack cell volume. Pack cell volume.
Pack cell volume.
Because look, like I said, yeah, because like I said, VOCs come and go, pain crises come and go, but there may be mixed crises. So a patient may have severe anemia alongside the vaso-occlusive crisis. So if you don't detect that and you're giving oral analgesics without giving that blood transfusion, that person may die. So if there's one test that you must do, your focus is to treat and to relieve. So I will say pack cell volume is one test that must be done if there's limited resources.
Thank you so much, Prof. So we have good comments about your presentation on the chat box. And then Augustine is saying that the multidisciplinary training in SCD has been very educative, and then we need more of those. Thank you so much for your comments. Yeah, so we'll go to the questions. Yes, how should the dosing of opioids and the frequency? How should the dosing of opioids and the frequency be?
Yes, so the opioids come in various forms. The weak opioids, like, let me just focus on what we have at least at hand. If you're using DF-118 for an adult, if you don't have morphine, then it's given every 8 hours. I didn't say TD, I said every 8 hours, but that interval is for every 8 hours. But if you're using something like morphine, then it depends on the formulation. That is slow-release morphine tablets. So the slow-release morphine tablets is given every 12 hours. And the minimum dosage is 10 milligrams. There are also, yes, but you also have the liquid oral morphine, which is used mainly in the children, all right? And that one has a short lifespan, half-life, and is given every 4 hours. So for liquid oral morphine, every 4 hours. Slow release every 12 hours. Now, there are other opioids that can be used, all right, and the dosage frequency will depend on the exact opioid that is being used. Pentazocine is still widely used for sickle cell disease pain in Nigeria. And I think it's an abuse. You realize that I mentioned it only once, and I almost tried to avoid mentioning it. Morphine, that people fear is a drug of addiction, hardly ever causes addiction as long as there's pain. It is pentazocine that causes addiction and should be avoided in sickle cell disease. It's only if maybe perioperatively or post-operatively you want to relieve the pain, patient is nil oris, and you don't have intravenous morphine. If you have IV morphine, then give IV morphine. But pentazocine, apart from the fact that it may have some cardiac side effect, given it intramuscularly, it is given orally. The dose is 1 milligram per kg per dose, and the ampoule comes in 30 milligrams. That can be given every 8 hours. But one should avoid it as much as possible because it causes addiction a great deal. In fact, many of our patients, teenagers, that's why transition care is so important. Many of our teenagers, some not many, a few teenagers that transit from pediatric care into adult care, and they go to the university campus, they get introduced to pentazocine, they get addicted to pentazocine, and then it just goes on and on. So it's something I want to avoid, but it can be given every 3 hours if it must be given, if there is no alternative to it.
Okay, Prof. Thank you so much. The other question by Professor Fakuri is still there, close to what you just said about pentazocine. But Professor Samuel Adegoke is raising his hand, so please unmute and speak. Then afterwards, we'll continue with the questions from the chat. But please feel free to use the chat box to send in your questions. And we're also going to post the post-test in. And also for those who want the slide, we have an attendance link. Please feel free to fill those and we'll send in the presentations. Professor Samuel Adegoke, please go ahead.
Thank you so much for the opportunity. I want to thank Professor Brown for the presentation. Thank you, sir. Recently, I was faced with a stiff opposition by one nephrologist on the use of non-steroidal anti-inflammatory drugs to control pain for our patient with sickle cell. We all know that sickle cell, they are at higher risk of having renal problems. And we also know that all these non-steroidal anti-inflammatory drugs, especially when used chronically, can also lead to renal problems. So, Professor Brown, sorry, what's your comment about the use of all these non-steroidal anti-inflammatory agents vis-a-vis renal problems, sir?
Yes, so it's very simple. Thank you for your question. The point is, how long does the VOC last? How long? It's not like cancer that you're treating chronic cancer pain. The pain here is very often a short-lived pain, and the patient you have treated over the years with ibuprofen and other analgesics, how many have come down with kidney disease? Kidney disease in sickle cell disease is very usually an outcome of progressive kidney damage, kidney injury from childhood, and then manifests in adulthood, like about the age of 40 years. So when I have everything at my disposal, I would rather see her start with a non-opioid than give an opioid drug. And the more potent non-opioids are the NSAIDs. Paracetamol, yes, it's good to start with it. You can start with paracetamol. But the current, practice is you assess that pain before you start. If that pain is not mild pain, it doesn't make sense to start with paracetamol. And it's better just go straight to the appropriate drug for that step of the ladder. So I think every drug has side effects. Even paracetamol has its own side effects. The opioids, you give you constipation, you need to give laxative to go along with it. The opioids can also affect the liver, and for sickle cell, you already have sickle cell hepatopathy. So giving a sedative to somebody who has a potential sedative to somebody who already has sickle cell hepatopathy, again, the risks are there. So putting all things together, I think that using NSAID when needed and stopping it when it's not needed anymore, it's a safe way to go, and I think one should carry on.
Thank you so much, Prof. Professor Adeoke, I hope that responds to your question. So,
yeah. Thank you, sir.
Okay, yeah. So, just to further, I know Prof has mentioned this in while responding to some of these questions. Just Professor Fakuri has just added that pentazocine is still widely used for sickle cell pain management in Nigeria because of its ready availability, despite concerns about dependency and addiction. Then what's your take on this? How can we increase access to morphine and other strong opioids in Nigeria? I'll also take the next question, which says hydroxyurea is a cytotoxic agent with anti-metabolite activity. Is there a role of vitamin B2 in patients on SCD, patients with SCD on hydroxyurea? So, Prof, if you can take those two together. Thank you.
Okay, so the first question was, I forgot, I didn't take it down.
Yeah, so the first question is about pentazocine addiction.
Oh,
What can be done? Yes, yeah.
So I think the issue is the federal government. You can buy pentazocine off the counter without a prescription from a doctor. And the government should ensure that pharmacists only dispense that drug when there's a prescription from a doctor. If there isn't any, then they'll keep on buying it across the counter and getting dependent on it and getting addicted to it. All right, so that's one. Two, what can we do to make morphine more available across the country? Simple, it's accountability. If somebody prescribes morphine for you, I go to the pharmacy, the pharmacist gives you the morphine, they will keep your prescription as record. So at the time that when the drugs are getting finished and they want to restock, they can present this evidence that we didn't use this drug for ourselves and that patients use these drugs, and then you have a refill. All right, but very often, so that is it. So that one issue. Second issue is that doctors are afraid of addiction using morphine, which is very, really unfounded. As long as there is pain in an individual, that person cannot become dependent on morphine. So that was it. Once upon a time, there was a lot of morphine at the national stores at Yaba. They stayed at Yaba and they expired because the country didn't use it, because the doctors didn't use it. Doctors like in our place, we call surgeons, physicians, but I'm part of the UCH and palliative care team. I've been training palliative care in Uganda. And we trained these people on the safety of morphine, to use morphine to relieve pain. They are all still skeptical that it causes dependence and addiction. And to my amazement, even in Uganda, where I was trained on palliative care, the Uganda Cancer Institute, the doctors there also, in treating cancer, do not want, at that time, even the doctors in the Cancer Institute did not prescribe morphine. They had that same fear that it will cause dependence. And that's what makes it to expire. I mean, it expires that way, it's not used. The background body organization that regulate supply of morphine will find it difficult giving you another stock when the first stock of morphine was abandoned. So if the uptake is increased, I'm sure that the government will import more of it, they will distribute it more, it will become more available for people to use. That's my own take on that. Thank you.
Thank you so much, Prof. Thank you. So another question, because we have actually spent much time in these presentations, though they were very exciting and engaging, but we really want to come to an end of today's presentation so that we can do a little housekeeping for tomorrow's presentation. So one question says, for patients with mixed crisis, how should the fluid therapy be? As giving fluids may tilt a patient with severe anemia into heart failure. Thank you.
Yes, so the key point there is that, so if they have mixed crisis, your management will depend on a number of factors. One, what is the second form of crisis? If they have mixed crisis, VOC, plus hyperhemolytic crisis, you still give them fluid at maintenance. Otherwise, the hemoglobin from the lyse red blood cells will cause acute kidney injury. But beyond that, you also give them your sodium bicarbonate to alkalinize the urine and minimizes the risk of hemoglobin precipitates blocking the tubule. If the VOC is being combined, now using the wrong term now, acute chest syndrome, because acute chest syndrome is a form of VOC. So if you're having pain in your extremities along with acute chest syndrome, you're not sure what's going on in the acute chest syndrome. Is it an infection in the lungs? Is it an infection from vasoocclusion? Then you just monitor. You give maintenance. If the patient is euvolemic, just to give maintenance. The best is that give it orally. You are less likely to have fluid overload from taking drugs orally than by giving from taking fluids orally than by giving fluids orally. If they have the VOC with aplastic crisis, then the fluids you give, there's no fear in that. But aplastic crisis, you're not having cause hypervolemia or pulmonary congestion. So you still give your fluids at that maintenance. Maintenance is just what is required for the day, and there is no harm with it. So it will depend. All these are if the patient is euvolemic. But if the patient was dehydrated, then you need to give more fluids. If the patient already has fluid overload or already in anemic heart failure, then you will need to cut down the volume of fluids that you are. So if you have VOC and anemic heart failure, then you need to cut down the volume of fluids that you give to one oral drugs, if tolerable, oral drugs and not IV, and then maybe three-quarter maintenance or something like that, just to ensure when you monitor closely, and then you tailor your treatment based on the outcome that you see between, so that you don't take the patient from being euvolemic to hypervolemic or vice versa. Thank you.
Thank you so much, Prof, for those responses. If you are still interested in getting the presentations, please fill the attendance form. The link is on the chat box. We're going to send it out because the attendance has your name, your email, and then your institution where you're calling it from. So please fill it in. We'll also send a link to the recordings, and then the presentations too will be shared. So please fill it in. And then we have the post test for all the wonderful presentations today. We also want you to, please access that link and fill it as best as you can. We have successfully come to the end of today's presentations. I want to invite the PI and Director of Center of Excellence for Sickle Cell Disease to give us some closing remarks. And I want to sincerely appreciate all the presenters who have made their presentations today. They were exceptional, excellent presentations. So thank you so much. Professor Nodi, if you're on the call, please, we need a closing remark. And thank you, yeah.
Yes, I would say that thank you very much, Ruben, for excellent moderation. We have enjoyed listening to these exciting presentations. And I want to thank everyone, all the SPACO PIs. I noticed all of them, most of them were here. Professor Akiola, good afternoon, ma. Just to acknowledge the presence of all the PIs and to thank all the participants, especially those who asked questions. I want to thank Professor Adegoke for moderating, all the way, doing this presentation all the way. I thank Professor Maxwell. I thank Dr. Issa. Dr. said that was really wonderful. So I thank all the presenters and all the participants. And, for today's session, we look forward to more. So tomorrow is very important presentation on management of stroke, by Professor Fred Sappho. Professor Fred Sappho is the PI, the MPI on this study and the PI for Ghana SPACO. He has a very good assessment tool for stroke in low middle income countries, which he has developed. I'm really excited. I'm looking forward to hearing from him. So I would like you to please invite the pediatricians in your hospital, and also, the nurses, the lab people. Please invite them so that we'll be a fuller house tomorrow. It will be very exciting. So thank you so much. And I thank the managers at SESTA and all the people from SESTA, and all the institutions. Thank you so much. God bless you. Thank you.
Thank you so much. See you all tomorrow, 10 a.m. West African time. Thank you.
Okay, they said that they cannot, the link for the form is not working, but I was able to sign in. Maybe we will send to the chats, and the same way you received the message to come to the meeting. Maybe we will try that. Thank you very much. Okay.
Thank you very much, Prof. Well done. Great coordination and great leadership.
Professor Brown, I'm really excited that you were able to join. Thank you for the sacrifice. Well done.
Thank you.
Yeah.